Good evening everyone. Hopefully I'm audible. Please let me know if the audio visuals are clear so we can proceed, bache. Chalo, hopefully I'm audible. Now let's today discuss the important previous year questions of ENT as well, right? So hopefully all of you will be active throughout the session in the chat box. Clear? So once we are done with this session, we'll do this session for 2.5 hours around, okay, and then we'll take a break, and then at 10 o'clock or 10 p.m. as I told you, I'll conduct a one-liner session in the Telegram group. Hopefully all of you are active over there as well in the Telegram. Okay, so every day I'll be conducting at 10 p.m. the one-liner session in the Telegram, which is a rapid fire one. So hopefully you were active yesterday, and today also you'll be active over there as well. Okay, sure. Okay, I'll let you know bache about that. Now let's talk about the question number 1. Easy one, important one, recent NEET PG as well. So a patient was suffering from peritonsillar abscess. We know beta what is peritonsillar abscess. Collection of pus around the tonsils in the peritonsillar space is known as peritonsillar abscess. We know peritonsillar abscess is nothing else but another name for quinsy, bache, right? So here the patient is having peritonsillar abscess or quinsy, and he was experiencing throat pain. Obviously, as the infection is inside the throat or around the tonsils, the patient is having throat pain, but with a referred otalgia. And this is important, beta. Referred otalgia the patient is having, right? So referred otalgia means the patient is also having ear ache, beta. So the pain is over here, but it is also referred to the ear of the patient. Which among the following nerve is likely responsible for this, beta? Which among the following nerve is likely responsible for this? Hello, beta. So please let me know which among the following nerve is likely responsible for this. बेटा जल्दबाजी में आंसर नहीं करना, मैं पहले बता रहा हूँ. Just think about it. Patient is having throat pain, and due to that, beta, as the nerve is getting irritated over here, the patient is also having pain inside the ear, beta. There is a referred otalgia in the patient. No, bache, it cannot be Arnold's nerve. Let's discuss about this. So basically, this is what is the picture of your oropharynx, beta. Now in oropharynx, we know the base is formed by the tongue. Okay, the roof is formed by the soft palate and the uvula, beta. On the lateral aspect, we have the two tonsillar pillars, beta, the anterior and the posterior tonsillar pillar, and in that we have the tonsillar fossa. In that tonsillar fossa on the lateral side, beta, we have this purple color tonsil over here, right? Now important is, can you see at the base of this purple color tonsil, we have this green color capsule, beta, okay? Then we have this yellow color space. What is this yellow color space called as? This yellow color space is known as the peritonsillar space, beta. Right, this yellow color space over here is known as the peritonsillar space, bache. And in this peritonsillar space, if there is collection of pus, that is called as a peritonsillar abscess or quinsy, beta. In that peritonsillar space itself, you are able to see a vein called as the paratonsillar vein. Then definitely we have a muscle, beta, and that muscle is known as the superior constrictor muscle, which forms the bed of the tonsil. Yes. So if they ask you, this has been an important question. If they ask you that bed of tonsil is formed by, do you remember that bed of tonsils is usually formed by a muscle known as the superior constrictor muscle. Now beyond the bed of tonsil, beta, lateral to the bed of tonsil or lateral to the superior constrictor muscle, this blue color space that I am highlighting, this blue space is known as the paratonsillar space, beta. समझ गए? This blue space out here, or that space that I am highlighting, is known as the paratonsillar space. And in this space if there is collection of pus beta, that is known as a parapharyngeal abscess. Now in the paratonsillar space or in the peritonsillar space, you are able to see this nerve over here. Can you see one artery is there, that is the facial artery, and one branch of the facial artery is supplying the tonsils beta. So if they ask you what is the blood supply of tonsil, do remember that the blood supply of the palatine tonsils is the tonsillar branch of facial artery beta. Okay? And it drains into which vein? So we know it drains into the paratonsillar vein. Now important is, in the bed of the tonsil we also have one more nerve beta. And what is that nerve? That nerve is known as the glossopharyngeal nerve, bitch, and we know that glossopharyngeal nerve is the 9th cranial nerve, right? Glossopharyngeal nerve is the 9th cranial nerve. Now what happens is, there are multiple conditions. For example, if a patient is having tonsillitis, or if the patient is having a peritonsillar abscess, that is quinsy, or the patient is having a parapharyngeal abscess beta, in all these conditions what will happen? This glossopharyngeal nerve will get irritated, and as this glossopharyngeal nerve is irritated beta, therefore we know that a nerve, wherever it is irritated, it causes problem everywhere it goes. That means in each and every branch of that nerve beta, you may be able to see problems. That is, even if the glossopharyngeal nerve is irritated in the throat, due to that the patient is having throat pain, but we know one branch of the glossopharyngeal nerve also goes and supplies the middle ear beta. We know middle ear is known as tympanum, therefore that tympanic branch of the glossopharyngeal nerve which supplies the middle ear is known as, anybody? What is that tympanic branch of glossopharyngeal nerve which supplies the middle ear is called as? So either you can answer it as this referred otalgia in the patient is due to irritation of the glossopharyngeal nerve or your 9th cranial nerve, but glossopharyngeal nerve is not an option. So it is actually the tympanic branch of glossopharyngeal nerve which is responsible for this referred otalgia or referred earache beta. And what is that answer now? Hello? Very good. So the answer to this question has to be option D, bache, that is Jacobson's nerve. We have to remember that if I talk about the Jacobson's nerve which is there beta, so Jacobson's nerve is actually the tympanic branch. Jacobson's nerve which is there beta, it is actually the tympanic branch of glossopharyngeal nerve. Yes, it is the tympanic branch of glossopharyngeal nerve or your 9th cranial nerve beta. So whenever the 9th cranial nerve is irritated, even this Jacobson's nerve gets irritated, and that's the reason the patient is going to have beta pain in the middle ear or pain in the ear beta. This is the reason for the referred otalgia in the patient. Clear? So that has to be remembered. Either glossopharyngeal nerve or Jacobson's nerve will be there in the option. Now what are the reasons for referred otalgia? What are the causes for referred otalgia? One condition I've already told you, beta, tonsillitis, that can cause irritation of the glossopharyngeal nerve. Second condition is described in the question itself, that is peritonsillar abscess, also known as quinsy. Third condition I told you, it is also known as parapharyngeal abscess. In that also the patient may have irritation of the glossopharyngeal nerve. Okay, and an important condition beta during surgery. Now for example, if you are doing a tonsillectomy beta, removal of the tonsils, at that time during dissection or during separation of the tonsils beta, you may damage the nerve in bed of tonsil. So during tonsillectomy surgery beta also there is a chance that you may cause damage to this. And I hope all of you are quite aware about that condition where there is a very long styloid process beta, and that long styloid process causes irritation to the glossopharyngeal nerve. A long styloid process may cause irritation to the glossopharyngeal nerve in the bed of tonsil. And what is that condition called as? Where the patient has throat pain along with a referred otalgia. What is that condition called as? Long styloid process irritating the glossopharyngeal nerve. That condition is classically referred to as styalgia beta. By the name it is evident. See, that condition which is there beta is known as styalgia. That is the long styloid process causing algia, that is pain beta, also called as Eagle syndrome. Okay, so styalgia or Eagle syndrome. Treatment is styloidectomy. Removal of that extra part of styloid process has to be done. Clear? So these are the conditions beta in which the patient may experience referred otalgia, okay, due to irritation of the glossopharyngeal nerve or its branch known as Jacobson's nerve. Now important is median nerve which is there beta. If I talk about this median out here, we know that if this median nerve gets stimulated, we know median nerve is also known as nerve of pterygoid canal beta. If there is overstimulation of median nerve beta, we know that median nerve gives which kind of supply? Median nerve gives parasympathetic supply to the nasal mucosa, which is median nerve gives parasympathetic supply to the nasal mucosa. So if there is stimulation or irritation of the median nerve beta, there is increased parasympathetic activity. There is increased parasympathetic activity in the nasal mucosa beta, and that's the reason the patient is going to have a continuous watery nasal discharge. The patient is going to have a continuous watery nasal discharge. What is that condition called as? Whenever the patient goes into cold temperatures beta, and due to that cold temperatures there is irritation or overactivation of the median nerve, which causes increased parasympathetic activity in nasal mucosa, leading to excessive watery nasal discharge in the patient. What is that condition known as? Bolo. That condition is known as vasomotor rhinitis, that condition which is there is known as vasomotor rhinitis. And do remember that in patients of vasomotor rhinitis, the treatment has to be nervectomy beta. Median nervectomy has to be done. Okay? So that is important. Yaad rakhna, on cold exposure, if there is excessive watery nasal discharge, that is usually due to irritation of median nerve, due to overactivity, over parasympathetic activity in the nasal mucosa, and the treatment of this condition known as vasomotor rhinitis is median nervectomy, removal of the median nerve. Clear? Next important beta is the nerve of Würzburg. We know beta the nerve of Würzburg which is there, it is actually the sensory division of the facial nerve beta, and this sensory division of facial nerve which is there, it is going to supply the postero-superior part of external auditory canal. Okay, but please remember beta, if there is damage to this nerve of Würzburg, if there is damage to this nerve of Würzburg beta, okay, injury to this nerve of Würzburg is going to cause loss of sensations in the postero-superior part of ESC. And what is that sign called as, anybody? Damage to the nerve of Würzburg or the sensory division of facial nerve causes loss of sensations in the postero-superior part of external auditory canal, and that sign is called as, bolo, that sign is basically known as the Hitzelberger sign. Bolo, Hitzelberger sign is a feature of, Hitzelberger sign is usually seen in a case of, Hitzelberger sign is usually seen in a patient of. So do remember that beta, Hitzelberger sign is usually seen in a patient of very good, shabash. So it is usually seen in a patient suffering from acoustic neuroma beta. So we know that acoustic neuroma is a benign tumor arising from the 8th cranial nerve or the vestibulocochlear nerve. So in patients of acoustic neuroma beta, the most common cranial nerve involved is the 8th cranial nerve. The second most common cranial nerve involved is the 5th cranial nerve, that is your trigeminal nerve. But apart from that, even the sensory division of facial nerve can get involved beta, third most common. And that sensory division of facial nerve is Würzburg nerve. So when the tumor involves this Würzburg nerve beta, that causes loss of sensations in the postero-superior part of EAC, and that is what is known as the Hitzelberger sign. Hopefully that's clear to all of you now. Okay? So that is important. When Arnold's nerve will get stimulated, we know bache that Arnold's nerve is a auricular branch of the vagus nerve beta. Yes, so it is the auricular branch which supplies the external auditory canal beta. Okay, and it arises from the vagus nerve. Now we know beta that ear syringing should always be done in a postero-superior manner. But if ear syringing is done in the antero-inferior manner, you are actually going to irritate the floor of the external auditory canal. And if you irritate the floor of external auditory canal beta, due to that, the Arnold's nerve or the auricular branch of vagus nerve gets irritated, and due to that, the patient may experience problems like cuff reflex or vasovagal syncope beta. Okay? Problems like cuff reflex or vasovagal syncope if the patient experiences after ear syringing. That is due to irritation of the Arnold's nerve. Clear? So that has to be remembered. We'll discuss about it in a while. Hopefully that's very clear to all of you now. These are the important nerve injuries beta, at least for which you have to remember in ENT. Clear? Important question from here. 1 point. If they ask you that which is the most common vessel to bleed during tonsillectomy surgery, do remember this was a PYQ. So the most common vessel, okay, the most common vessel to bleed, okay, most common vessel to bleed during the tonsillectomy surgery beta, during the tonsillectomy surgery has to be this paratonsillar vein. Okay, while removing the tonsils, most of the time this vessel gets nicked or this vessel gets injured beta, and that causes bleeding. So please remember, paratonsillar vein is the most common vessel to bleed during the tonsillectomy surgery. Hopefully that's clear to all of you now. Okay, so do remember these things. These are the important points to be remembered. Next one, question number 2 now. Answer, easy one, very. Here we have a question that states we have a 35-year-old lady beta, 35-year-old lady, while cleaning her ear, okay, while cleaning her ear with a hairpin, accidentally damaged her eardrum beta, that is your tympanic membrane. She has accidentally damaged her tympanic membrane or the eardrum. Okay, what is the best management बच्चे? What is the best management of traumatic ear perforation, traumatic tympanic membrane perforation or traumatic eardrum perforation? बोलो. What is the best management for a traumatic ear tympanic membrane perforation? Very good. Yes, shabash. So please remember beta. Very good. So do remember that there can be a tympanic membrane perforation बच्चे. Tympanic membrane perforation can be of two types. Either it is traumatic or non-traumatic. So the traumatic tympanic membrane perforation can occur due to various reasons. One of the reasons has been mentioned in the question, like a hairpin injury. Another reason can be slap beta. That has been a previous year question of your exam, that the teacher has slapped a student and after that the patient is having mild conductive hearing loss. So even a slap can lead to a traumatic tympanic membrane perforation beta, or it can be even a sudden exposure to loud sound. Like for example, you go very close to a DJ beta. So sudden exposure of 150 to 160 decibels, 150 to 160 decibels of sound can also lead to a traumatic tympanic membrane perforation बच्चे. Okay, that is one condition. Second is if there is infection beta. Infective tympanic membrane perforation. Infective can be usually due to middle ear infections beta. That is called as otitis media. Usually those can lead to a trauma. Those can lead to an infective tympanic membrane perforation. Now traumatic ones which are there beta, they are self-healing or self-resolving. मतलब अपने आप ठीक हो जाते बेटा. They usually heal by themselves. You do not need any kind of treatment. ठीक है? So please remember the treatment in this patient has to be either no treatment, or you can mark it as reassurance. Okay, you can mark it as reassurance, or you can mark it as conservative management beta, whatever is there in the option. Okay, so that has to be mentioned. And why we have to do reassurance, no treatment or conservative management? Because it is self-resolving within a span of 3 to 6 months beta. It is self-resolving. It will get healed by itself within a span of 3 to 6 months. Yes, even after 6 months, if it doesn't heal beta, then you may go for a surgery beta for the closure. And you have to repair the tympanic membrane. Repair is called as plasty vache. And tympanic membrane is known as myring. Therefore, that surgery will be called as a myringoplasty when we close the tympanic membrane perforation with a graft beta. Okay? Now, in infective tympanic membrane perforations beta, do remember infective tympanic membrane perforations will never get healed by themselves. You have to treat the infective tympanic membrane perforation. वो अपने आप ठीक नहीं हो सकते बेटा. That has to be remembered. Therefore, here it is always a surgery that is nothing else but myringoplasty beta. ठीक है? You will obviously give antibiotics and everything, but along with that, the definitive management will be myringoplasty. And this myringoplasty which is there beta, please tell me for this, which is the most common graft used for myringoplasty surgery? To close the tympanic membrane perforation beta, what is the most common graft used for myringoplasty surgery? What is the most common graft used for myringoplasty surgery? Now here definitely for middle ear infections beta, we give an incision either over here or over here. Okay? So from the same incision I can just extend the incision over here, and this is the muscle beta which has a covering or a fascia called as a temporalis fascia beta. So I can just take that temporalis fascia and we can use it as a graft beta for the purpose of myringoplasty. So temporalis fascia which is there beta is the most commonly used graft for the purpose of myringoplasty. Okay, clear to all of you now? That has to be remembered. Okay? So now as it is a traumatic tympanic membrane perforation, so the management has to be either reassurance or conservative management. Answer for this question has to be option C बच्चे, that is nothing else but conservative management. ठीक है? So do remember that. Immediate myringoplasty not done, it is done in infective ones. ठीक है? It is not an infection, so no antibiotic ear drops are recommended. Myringotomy which is there beta, myringotomy is done for two conditions. Do remember. What is myringotomy? Making an incision over the tympanic membrane to drain something. So for example, it is done in case of ASOM beta. Okay, why in ASOM? ASOM is acute suppurative otitis media. So it is a middle ear infection which has a lot of pus in the middle ear. So when in patients of ASOM beta, there is excess amount of pus collected in the middle ear. Okay, that leads to a full or a bulging out tympanic membrane. In that condition, it's better to make an incision over the tympanic membrane and drain all the pus beta. Do remember that here in case of ASOM, the incision which is made beta, it is usually made in the posterior-inferior quadrant. So you can just remember for pus drainage which is there beta. Okay? So for pus drainage which is there, the incision is made in the posterior-inferior quadrant beta. Okay? So that is important. Next condition is serous otitis media, which we know serous otitis media is nothing else but glue ear. So in patients of glue ear or serous otitis media, also called as secretory otitis media, when there is collection of a sterile, infective नहीं होता बेटा, ये non infective होता है, ठीक है. तो when there is collection of sterile or a non infective glue like fluid in the middle ear cavity बेटा, that condition is serous otitis media or glue ear. In that condition also we have to make an incision, but that is usually made in the antero-inferior quadrant beta. That incision which is there, it is usually made in the antero-inferior quadrant to drain all the fluid which is collected beta. Okay? So hopefully that's clear. And after doing that incision in the antero-inferior quadrant beta, what we insert over there? Anybody? We have to insert a middle ear ventilation tube beta. After doing myringotomy in the antero-inferior quadrant in a patient of glue ear or serous otitis media, we have to insert a middle ear ventilation tube. What is that called as? Very good. So please remember beta that middle ear ventilation tube which is there, it is known as grommet. So that grommet should get inserted. Clear? So that is important. Chalo. So grommet insertion, myringotomy and grommet insertion is the management of glue ear beta. Clear to all of you? Now few conditions that you have to remember. What is this condition? Do tell me in the chat box. What is this condition? Patient comes, अगर वो बस spot diagnosis पूछते हैं बेटा in this condition, what do you think is the spot diagnosis of this condition? Important question beta. It's confusing. A lot of people do get confused. I'm not sure why, but yeah, they do get confused with glue ear and this condition. So now what is seen? You are able to see beta congested, red and inflamed tympanic membrane. And on that beta you are able to see bubbles, or we can say definitely there are blisters which are formed. Okay. So these bulla or blisters are usually formed on the surface of an inflamed tympanic membrane. So this is actually a condition of a infection of tympanic membrane. And this infection of tympanic membrane is called as myringitis bullosa or bullous myringitis beta. Okay, this condition is known as myringitis bullosa, okay, or bullous myringitis. By the name it is evident na, myringitis means infection or inflammation of tympanic membrane. Bullosa matlab bulle are formed over the surface of tympanic membrane. So myringitis bullosa or bullous myringitis is the condition. It is due to infection. Antibiotic eardrops have to be given to the patient beta for the treatment. Clear? So that has to be remembered beta. Next, what is this over here? This what you are talking about beta is this condition over here. And what is this? Here you are able to see now the inflammation is actually not on the tympanic membrane. It is behind the tympanic membrane. That means inside the middle ear cavity beta the infection is. But due to that there is dilatation of the capillaries on the surface of tympanic membrane. And these dilated capillaries on the surface of tympanic membrane gives you a very classical appearance. And this classical appearance out here is known as the cartwheel appearance beta. This classical appearance over here is known as the cartwheel appearance. And cartwheel appearance is seen in which condition? Anybody? Cartwheel appearance is seen in which condition? So do remember that the cartwheel appearance which is there beta, it is usually seen in patients suffering from ASOM beta. Cartwheel appearance is usually seen in patients suffering from ASOM, acute suppurative otitis media. Can anybody tell me in the chat box that which is the most common group of organisms which can lead to ASOM in the patient beta? Most common group of organisms or bacteria which can lead to ASOM in a patient. Acute suppurative otitis media. Otitis media is middle ear infection. Suppurative means pus forming infection beta. And here if the patient comes to you beta, the patient's main complaint is just earache. Yes, severe earache the patient is going to have. And due to pus in the middle ear, the patient may have some mild to moderate conductive hearing loss. That's the only complaint of the patient beta. Treatment, if they ask you, the treatment has to be antibiotics beta. Okay? So antibiotics have to be given. And oral antibiotics are required beta. Reason is the infection is in the middle ear. Okay? So you have to give oral or systemic antibiotics to the patient. Very good. The most common cause of ASOM is very good, Streptococcus pneumoniae beta. So Streptococcus pneumoniae is the most common cause of ASOM. Reason beta, the infection usually spreads from the throat or from the eustachian tube. So the middle ear is a closed cavity, na, we all know. So infection in the middle ear comes from the eustachian tube. So the source of infection is the eustachian tube, and the cause would be the same, that is, it is Streptococcus pneumoniae. Clear? Now this is again a condition of ASOM beta. This is again a picture of ASOM, but here there is somewhat different. Again a cartwheel appearance is seen and everything is seen. Okay? So please tell me, here there is again a case of ASOM beta. Okay? But along with that cartwheel appearance, you are able to see one more feature, and what is that? Here again definitely ASOM is there, but there is somewhat different. Here there is a full or a bulging out tympanic membrane beta. Here there is a full or a bulging out tympanic membrane. Cartwheel appearance to dikh hi raha hai, that's fine. But apart from that, what else I am going to see beta? That is a full or a bulging out tympanic membrane. And this is important beta. Why? Because if they give you a case of ASOM like this, where the tympanic membrane appears full or bulging out, when there is a lot of pus inside the middle ear, which is almost pushing the tympanic membrane forward beta, this condition mein beta, there is a very high risk of rupture of the tympanic membrane. The tympanic membrane can undergo a rupture at any point of time. So it's better that you have to make an incision on the tympanic membrane and drain all the pus which is collected inside. So agar is condition mein treatment pucha gaya, so what is your answer now? If they ask you treatment in this condition beta, what is the answer now? Bolo. What is the treatment in this condition beta? Yes, don't worry, I'll share the PDF in the Telegram group itself. Very good. Here the treatment has to be myringotomy beta. Myringotomy is nothing else but making an incision on the tympanic membrane, as I told you, in the postero-inferior quadrant for the purpose of pus drainage. So यहाँ पे the treatment will be myringotomy along with antibiotics. Okay? So when there is only cartwheel appearance, only antibiotics are given. But if there is a full or a bulging out tympanic membrane, then myringotomy plus antibiotics have to be done. Clear? Chalo, shabash. Next condition is this beta. Here there is nothing else but collection of excess keratin over the tympanic membrane beta, due to which the tympanic membrane gets obliterated, it gets damaged over here, and the patient has hearing loss beta. This condition is called as keratosis obturans. Just remember the name, that is called as keratosis obturans beta, when there is excess keratin or debris collected over the tympanic membrane. That is known as keratosis obturans. Sure. Next, answer this question. Easy to remember, easy to answer. Here the question says beta, a patient of suspected sinusitis, okay, a patient of suspected sinusitis beta has undergone a CT scan of sinuses. The radiologist reports an anatomical variation of posterior ethmoidal air cell beta, which is lying in close proximity to the optic nerve. Identify this cell beta. Identify this cell over here. Very good. So we know beta, here the ethmoidal air cell should be present inside the or within the ethmoid bone beta, but here the ethmoidal air cell is actually present outside the body. That's the reason it is an ectopic ethmoidal air cell. If I talk about first of all the normal ethmoidal air cells beta, the normal ethmoidal air cells, we know that the empty spaces in the bones are called as sinuses or air cells beta. And in the four bones of the face four bones definitely in the face or head region, we have the sinuses: frontal sinus, ethmoid sinus, sphenoid sinus, and the maxillary sinus beta. So ethmoidal air cells are usually subdivided into two groups: anterior and the posterior ethmoidal air cells. Now important is, if they ask you beta one point about the normal ethmoidal air cell, which is the largest and the most constant anterior ethmoidal air cell? The largest and the most constant anterior ethmoidal air cell. Bolo. Largest and most constant anterior ethmoidal air cell. Very good. So the largest and most constant anterior ethmoidal air cell is known as bulla ethmoidalis beta. It is called as bulla ethmoidalis. Previous year question of your examination, bache. Previous year question of your examination. Where is bulla ethmoidalis present? Okay, where is bulla ethmoidalis present beta? Whether it is present in the superior turbinate, middle turbinate, inferior turbinate, or superior meatus, middle meatus, inferior meatus. कहाँ होता है? So what is the location of bulla ethmoidalis? That has been a question beta. What is the location of bulla ethmoidalis? बोलो. बोलो. So please remember beta, do remember this, that bulla ethmoidalis which is there beta, it is present inside the middle meatus. Okay, so do remember this was a question. So bulla ethmoidalis is present inside the middle meatus beta. Do not answer it as middle turbinate. Reason is, if middle turbinate में present है, then that becomes a ectopic ethmoidal air cell, not a normal ethmoidal air cell. याद रखना, ठीक है? So it is present inside the middle meatus. And second question, as most of you have answered also, the anterior most anterior ethmoidal air cell, if they ask you, the anterior most anterior ethmoidal air cell, if they ask you beta, answer has to be agar nasal. The answer has to be agar nasal. ठीक है? सबसे आगे is agar nasal. Now important, let's talk about few ectopic ethmoidal air cells beta. If I talk about the ectopic ethmoidal air cells which are present at some unusual sites beta. So these ectopic ethmoidal air cells, first of all, please tell me which is the most common ectopic ethmoidal air cell. Most common, bolo. Which is the most common ectopic ethmoidal air cell? Most common ectopic ethmoidal air cell, bolo. That is not ectopic beta, that is a normal ethmoidal air cell. Why it will be ectopic? Ectopic matlab which is present at some unusual site, uncommon site. So the most common ectopic ethmoidal air cell is called as conca bullosa butta. Most common ectopic ethmoidal air cell is known as conca bullosa. And where is conca bullosa present? So do remember that conca bullosa is present inside middle turbinate. So याद रखना ये बात. Inside middle meatus we have a normal air cell known as bulla ethmoidalis. And inside the middle turbinate, in the bone, we have a abnormal or ectopic ethmoidal air cell called as conca bullosa beta. That has to be remembered. Clear? Apart from that, definitely, another ectopic ethmoidal air cells can be the onodi cell beta. This onodi cell which is there, it is present along the optic nerve beta. Yes, along the second cranial nerve or the optic nerve, if you have a ectopic ethmoidal air cell, that is known as onodi cell. Okay? And last one which is there beta, it is called as the Holler cell. Last one is known as the Holler cell, and this Holler cell is present along the orbital floor. Okay, along the floor of the orbit or along the orbital floor, if you have it, that is known as the Holler cell. Clear? These are the ectopic ethmoidal air cells beta. One liner questions, do not forget them. Okay, so they have to be remembered. Now, so here if they are asking that the air cell which is there beta, it is lying in close proximity to the optic nerve. So your answer has to be option A, that is the onodi cell. We know along optic nerve, if that is present, it has to be option A, that is your onodi cell. Bache. Hopefully that's clear. Chalo. Now next, if I talk about beta, next question. Question number 29. Sarkari question. Bolo. Here we have a 29-year-old HIV positive individual beta. 29-year-old HIV positive individual who presents to us in the emergency bache. Okay, who presents to us in the emergency in a critical state beta with deranged vitals. The examination shows there is a reddish cheek. Okay, the examination shows there is reddish cheek along with some nasal obstruction, and there is periorbital swelling beta. And there is some periorbital swelling with blurring of vision, ठीक है, and loose upper teeth. What is the next line in management for this patient? What is your provisional diagnosis? First, let me know that in the chat box. What is your provisional diagnosis? Let me know that in the chat box. What is your provisional diagnosis, beta? The diagnosis तो बताओ. Very good. So the provisional diagnosis in this condition, very good. It is a classical case of mucormycosis, or we know beta that mucormycosis, as it commonly involves the nose beta, it may also involve the eyes or the orbit, and also involves the brain at times. Therefore, I can also call it as rhino-oculo-cerebral mucormycosis, right? To be specific, so we can remember all the things together. So it involves the nose, eyes and the brain beta, so it can also be called as rhino-oculo-cerebral mucormycosis. Okay? That's the reason beta. We know that this is a life-threatening fungal infection or a fulminant fungal infection beta, which is commonly caused by which fungus? So the cause which is there beta, the cause which is there, it is usually a fungus from the Zygomycetes species, which is, that is commonly Rhizopus followed by mucor. Yes, though mucor is in the name beta, common species which is going to cause it is actually Rhizopus. Common species to cause it is actually Rhizopus beta. Okay? So Rhizopus followed by mucor. Important is it is only going to cause this infection beta in immunocompromised patients like HIV positive patients, okay, or the patients who are elderly and diabetic patients, or the patients who are usually taking high doses of steroids beta. Like in cases of COVID-19 for treatment, we were using high doses of steroids beta, right? So it is usually going to happen in immunocompromised state itself. And this fungus which is there beta, it is an angioinvasive fungus. Angioinvasive ka matlab kya? It will also involve the blood vessels beta, and as it causes damage to the blood vessels, due to that the blood supply to the affected area decreases, and due to that decreased blood supply beta, there is ischemic necrosis, and due to that ischemic necrosis which happens beta, there is everything which appears black. Due to necrosis everything appears black beta, there is a black eschar which forms. So all that black mass and black spots and everything will be there. A lot of patients may also have beta mucormycosis which starts from the palate. Usually when you give nebulization of steroids now at a higher doses, the black spots will start from the palate. In some people it may start from the nose, okay, and then it will slowly involve the jaw also, it will slowly involve definitely the eyes of the patient and then the brain of the patient as well beta. Clear? So that is very clear of this. So here definitely there is reddish cheek, it is because of inflammation, nasal obstruction, periorbital swelling, blurring of vision, that is eye involvement is also there. Okay, loose upper teeth is also there beta, that means the palate is also involved. What is the next line for management in the patient? This is a recent NEET PG question beta. Okay, so please remember this is the recent NEET PG question that has come in your examination. Okay, so अगर इसमें बात करें तो option A says start antiretroviral therapy. No beta, if the patient is HIV positive already, maybe the patient is already on antiretroviral therapy. Even if the patient is not on antiretroviral therapy, now your priority is not HIV beta, your priority is mucormycosis as of now, because that is more life threatening than HIV. The HIV may cause damage on the long run. Right now it is mucor, so from which you have to save your patient. Now option B, C and D. Okay, now important is start liposomal amphotericin B infusion. See, though my clinical diagnosis is very classical beta, it is a case of mucormycosis, I know. But will I directly start the treatment, or I'll first of all rule out all the conditions? So that's the reason beta, I will not directly start the treatment beta. Please remember, I will not directly start the treatment bache. Liposomal amphotericin B is definitely the drug of choice, I know that. Okay, it is definitely the drug of choice. But I'm not going to directly start the treatment. My first priority is definitely to make a proper diagnosis, and then I'll move for the treatment beta. Now there are two options. Either it is send a nasal swab and debridement. So definitely I could send a nasal swab beta, but is it the first priority again? No. So here beta, do remember that here the first priority is option D, to perform a MRI head. Recent NEET PG question, so do remember that, do not get confused. Why to perform a MRI head on an urgent basis? We know that the mucormycosis has involved the palate, nose, even the eyes beta. So it's most important to rule out any brain involvement beta, or to rule out any cerebral involvement. So to rule out brain involvement beta, the first priority is usually given to MRI head in the patient. Okay, and once you definitely rule out the brain involvement beta, then you can definitely go for anything else. Clear? So that has to be remembered. Then definitely I can even send a nasal swab for mucor. I can definitely do a debridement as well. Okay? So please remember the first priority will be perform MRI head. Second, I can even send a nasal swab for mucor. Then definitely I'll start liposomal amphotericin B, which is the drug of choice. And finally the definitive management which is there beta, we know it is debridement itself. Yes. So yaad rakh lena beta, the definitive management which is there, definitive treatment which is there beta, it is surely what? So do remember, it is surely debridement, that is removal of all the necrotic tissue which is there beta. Okay, with or without, anybody, with or without exenteration. Now what is exenteration? Anybody, can you tell me in the chat box jaldi se? What is exenteration beta? What is the exenteration? Bolo. So we know beta, evisceration means removal of inner layers of the eyeball, okay, which is done usually in endophthalmitis or refractory endophthalmitis, or in patient sorry, okay. Next important condition which is there, it is enucleation. Enucleation, usually it is removal of the complete eyeball, okay, but not removing the extraocular muscles or the bones beta. That is done in cases of retinoblastoma or in patients of sympathetic ophthalmitis beta. Last is exenteration, when we remove the whole eyeball along with extraocular muscles along with the orbital bones beta. So if you also remove the orbit beta, so removal of orbit is known as exenteration. याद रखना, orbit मतलब bones also, yes, because we know in cases of mucormycosis even the orbital bones will undergo necrosis beta. That's the reason removal of orbit may or may not be done, so depending on the involvement. So that is what is exenteration. Clear? ठीक है, डिरेंज वाइटल्स है ना, तो फर्स्ट प्रायोरिटी के लिए आईवी फ्लूइड्स वगैरह है बेटा यहाँ पे. लाइपोसोमल एम्फोटेरेसिन बी, उसको डिरेंज वाइटल्स को ठीक कैसे करिए बताओ मुझे. इट कैन नॉट करेक्ट द डिरेंज वाइटल्स ऑफ द पेशेंट, राइट, दैट इज इंपॉर्टेंट. तो आईवी फ्लूइड्स बेसिक रेसिसिटेशन होता तो डेफिनेटली आई वुड हैव गॉन फॉर दैट एज द फर्स्ट चॉइस, बट वो है ही नहीं ऑप्शन में. लाइपोसोमल एम्फोटेरेसिन बी इज द ड्रग ऑफ चॉइस ना, इट कैन नॉट immediately correct the vitals of the patient. Got it? So that is important. So here this is the classical spectrum beta. Here you can see there is cellulitis, therefore there is periorbital inflammation and swelling. Here I can see palatal mucormycosis causing black spots, and here there is definitely a black eschar involving the face in the patient. Clear? Chalo, next question over here. Very classical and very easy. A 6-year-old school going child beta underwent tonsillectomy. He was shifted to the ward beta. He was shifted to the ward after an uneventful post-operative recovery period. Now we know uneventful matlab no adverse events or no problems have occurred after the surgery in the post-op period beta. In the evening, nursing sister notices that the patient is profusely bleeding beta. बहुत ज़्यादा खून आ रहा है. Profusely bleeding from the mouth, okay, from the surgical side. What is the best further management of the patient? बोलो. So hopefully what is your diagnosis over here? It is which kind of a surgical hemorrhage? It is which kind of a surgical hemorrhage, anybody? Can you give me a provisional diagnosis? It is which type of a surgical hemorrhage? Very good. All of you are right in the answer. मुझे diagnosis बताओ. Very good. Yes. So it is a classical diagnosis of reactionary hemorrhage beta. Shabash. It is a classical diagnosis of a reactionary hemorrhage. We know there are 3 types of surgical hemorrhages which are seen usually beta. So do remember that. Let's talk about them in a fast manner. So please remember there are 3 types of surgical hemorrhages. The hemorrhages of bleeding related to the surgery beta. The first type of surgical hemorrhage is called as a primary hemorrhage beta. If I talk about a primary hemorrhage, we know the cause of primary hemorrhage. First of all, what is primary hemorrhage? Any bleeding that happens during the surgery beta, when the surgery is going on, is called as primary hemorrhage. The cause of primary hemorrhage is iatrogenic. What is iatrogenic? While we are operating on the patient beta, by mistake we damage a blood vessel and that vessel starts bleeding. That bleeding vessel is called as a bleeder beta. So during the surgery, if there is any kind of bleeding beta, that is a primary hemorrhage, and the cause for that is iatrogenic or a bleeder. Okay? So the treatment for this condition would be what? So we know beta, if it is a large vessel, then I have to take a suture and I have to ligate the vessel beta. Ligation has to be done. But if it is a small vessel, I can just coagulate the vessel beta with the help of a cautery. So cauterization can be done for a smaller vessel. Clear? So that is about the primary hemorrhage beta. That is about the primary hemorrhage. Next type of hemorrhage which is there beta, it is called as a reactionary hemorrhage. Next type of hemorrhage which is there is known as a reactionary hemorrhage. If I talk about reactionary hemorrhage, मुझे timeline चाहिए अभी. Very good, shabash. So please remember, any bleed that happens within the first 24 hours of surgery beta is what is called as a reactionary hemorrhage. Yes. So any bleeding that happens within the 4 to 24 hours of surgery, any bleeding which happens within 4 to 24 hours of surgery, which is known as a reactionary hemorrhage. This is not only important from ENT but also a very important topic of surgery. Do remember that. Okay? So for all surgeries it is common. So any hemorrhage or bleeding from the surgical site within the first 4 to 24 hours of surgery is reactionary hemorrhage. The cause of reactionary hemorrhage which is there beta, it is the most common cause is slippage of knot or slippage of a ligature. Matlab, for example, during a surgery beta, you have taken a knot or you have tied a suture around a vessel beta, but that suture which is there, it has slipped off. The knot was very insecure, dhiri thi knot beta, and therefore it has opened up, and now the patient has started bleeding from that blood vessel bache. That is what is called a slippage of knot or a slippage of ligature. Very good. What should be the treatment in this condition then? As you have rightly answered, take the patient to the OT again beta, take the patient back to the operation theatre, and again go and find which vessel is exactly bleeding. That is, re-exploration of the surgical site should be done beta, and along with re-exploration you have to go for a religation as well. So re-exploration and religation of the surgical site has to be done. Hopefully that's clear. So go and search for the bleeding vessel, again take a proper suture, and this time tie a secure knot beta which will not slip off easily. Okay? The third type of a surgical hemorrhage which is there beta, it is a secondary hemorrhage. The third type of a surgical hemorrhage is a secondary hemorrhage. What is a secondary hemorrhage? What is the timeline, anybody? The bleeding or the hemorrhage which happens from the surgical site after how many days of surgery? After how many days of surgery beta? Anybody? The bleeding that usually happen beta after 24 hours can be considered, but agar पूछा जाए timeline beta usually, so please remember it is mostly more than 5 days. 95% cases are more than 5 days itself. Okay? So the better definition to be said is after 5 days of surgery. So any bleeding that happens from the surgical side beta after 5 days of surgery usually is considered as a secondary hemorrhage beta. So please remember it is 5 to 7 days in some books, but अगर minimum पूछा जाए तो minimum it should be 5 days. याद रखना ये बात बेटा, please remember that. ठीक है? So more than 5 days of surgery. And what is the cause for it beta? We know the cause for it is nothing else but the infection at the surgical site beta. Yes. So if it is a tonsillectomy surgery, that means infection in the tonsillar fossa is the cause of secondary hemorrhage. So infection at surgical site is the cause beta for a secondary hemorrhage in the patient. Infection at surgical site. And what is the treatment in the patient? We know the treatment of this patient. Obviously, if it is a bacterial infection beta, treatment has to be antibiotics. And the antibiotics should be given IV, intravenous. And obviously, if I have to give antibiotics intravenous beta, we have to admit the patient. Previous year question was, one option was IV antibiotics, another option was admission plus IV antibiotics. Do remember, IV antibiotics should be given on a IPD basis or a after admission. Reason, antibiotics may cause anaphylactic reactions. They were therefore never given on a OPD basis beta. याद रखना है बात. ठीक है? So admission plus IV antibiotics. ठीक है? No issues with this, anybody? So do choose the options wisely beta. Chalo, shabash. So here they have said beta that the patient was shifted to the ward after an uneventful post-operative recovery period. In the evening, nursing sister notices. So in the evening itself beta, that means within few hours of surgery itself, in the first 24 hours of surgery itself, the patient is having profuse bleeding from the surgical site or from the mouth beta. So it has to be a case of reactionary hemorrhage. Hopefully now it's clear to all of you, those who are having any doubt. Okay? Now what is the best further management? We know option C has to be answer. Immediate re-exploration in the operation theatre has to be done beta. It is normal to have bleeding in post-op period, so patient can be reassured and discharged. No, that's not true. Admission and IV antibiotics. If it was a case of a secondary hemorrhage, then we would have gone for that. Start oral hematinics? No, that's not only going to help beta. Clear? Chalo, very good all of you. Shabash. Next, answer this question out here. First make a diagnosis and then answer me. First you are going to make a diagnosis and then you are going to answer me. So here we have a question beta which says a teacher has been taking frequent, long and uninterrupted sessions beta. Frequent, long and uninterrupted sessions before the final examinations of the students. He has been complaining of hoarseness of voice beta for the last 1 month almost, and says 2 different frequency sounds are heard. Now what is this 2 different frequency sounds beta? If 2 different frequency sounds are heard from the same patient at the same point of time bache, these 2 different frequency sounds from same person at same point of time, is classically called as diplophonia बच्चे. This is classically called as diplophonia. So double frequency sounds or two frequency sounds in the same person is known as diplophonia. Along with that, whenever he speaks now, okay, whenever he speaks now, his laryngeal endoscopy picture is given in the image. What will be the best management of this patient, beta? What is the best management of the patient? Very good, shabash. So those who have made a correct diagnosis, shabash beta. Here you are able to see a outgrowth from the vocal cord, and this outgrowth which is there, it seems bigger in size beta. First, it seems to be more than 3 millimeters in size. Second, it is usually unilateral beta. Second, that outgrowth is usually unilateral. Okay? And therefore the diagnosis of this condition, the provisional diagnosis of this condition has to be a case of vocal polyp. Shabash all of you. It has to be a case of vocal polyp. Do remember this. Directly teacher देखते, कौन बोला कि टीचर में बस vocal nodules होता है? What is the cause for both the conditions beta? Whether it is a case of vocal polyp or it is a case of vocal nodule, the cause for both of them is same, na? The most common cause for both of them is same, that is vocal abuse, right? The cause for both these conditions is same beta, that is vocal abuse. Other causes can be LPR, that is laryngopharyngeal reflux, when the acid comes till the larynx or pharynx, or it can be smoking. But the commonest cause is vocal abuse for both the condition. So teacher may develop a polyp also and a nodule also. Who said that only a teacher develops only a nodule beta? So do remember that, how to make a difference. Very good. The cause is same, vocal abuse. Another thing, even the location is same beta, it is at the junction of, this is the anterior part, this is the posterior part. So it is at the junction of anterior 1/3. It is at the junction of anterior 1/3 and posterior 2/3 of the vocal cord beta. It is at the junction of anterior 1/3 and posterior 2/3 of the vocal cord. Reason beta, this is the most vibrating part. This is the part where there will be maximum vibrations. As this is the part having maximum vibration beta, therefore the most common site has to be junction of anterior 1/3 and posterior 2/3 of vocal cord. Okay, for both the conditions I am saying, even for a vocal nodule as well as for a vocal polyp beta. Okay, so do remember that. Okay, so what is the difference then? The main complaint also for both the conditions is same beta. The most common complaint of both the conditions is going to be hoarseness of voice. As there is damage to the vocal cord, in both the conditions the complaint is hoarseness of voice. Yes, in polyp there may be an additional symptom, that is diplophonia. Diplophonia is an additional symptom of polyp beta which may not be seen in nodules. Reason beta, because the sound which is produced from this part, normal part of the vocal cord, will have a different frequency, and the sound which is produced from this edematous polyp will have a different frequency. That's the reason, same person, same point of time, two different frequencies of sound. So diplophonia is more classical of polyp than a nodule beta. That has to be remembered. Second, here you are able to see beta small nodular elevations on both the vocal cord. So first condition, it is very small in size, that is less than 3 mm in size. Second thing that has to be remembered, it is always bilateral. Second thing that has to be remembered, it is always bilateral. Okay, this is a classical case of a vocal nodules. Now here also the most common cause is same, vocal abuse. The most common site is same, junction of anterior 1/3 and posterior 2/3. Okay, most common symptom is same, that is nothing else but hoarseness of voice. But this is the basic difference. Have you understood this basically? Clear beta? Now no mistake to be done. If it is a case of a vocal nodule beta, the treatment of the patient is usually beta, vocal rest has to be advised initially. Okay, along with vocal rest or voice rest, the patient may also need a speech therapy beta at times. This patient may also need a speech therapy at times. Most of the people may get better with vocal rest, but some of the patients may also need a speech therapy. Okay. Next important beta, if I talk about a vocal polyp, here what is the best treatment beta? They have asked you best treatment approach. So the best treatment approach has to be a microlaryngeal surgery. What is a microlaryngeal surgery? Any surgery that is done on the vocal cords beta under microscope, because obviously vocal cords are a very small structure. So any surgery that is done on the vocal cords under microscope is called as MLS or microlaryngeal surgery. And this microlaryngeal surgery which is there beta, here we have to do a surgical excision or surgical removal of that vocal polyp. Okay, we have to do a surgical excision or a surgical removal of that vocal polyp. And nowadays for this excision beta, we use a CO2 laser commonly. Nowadays for this excision beta we use the commonly CO2 laser. So you can say CO2 laser excision, you can see a microlaryngeal surgery, you can see a removal of the polyp, जो भी बोलो, ठीक है? That has to be the best management. Along with that, yes, here also as the cause is vocal abuse beta, here also the cause is vocal abuse. Here also you have to recommend voice rest to the patient बच्चे. Okay, you have to recommend voice rest to the patient along with speech therapy. ठीक है? So these three things will be recommended, but out of them, what is the best one? Best one is to remove the polyp, and therefore answer has to be option C. बाकी दो भी करेंगे. Even we will give vocal rest and speech therapy in the patient. PPIs are given if the cause seems to be a LPR beta. What is LPR? Laryngopharyngeal reflux. So a patient of GERD itself develops a LPR beta. In that condition, we may need to give a PPR as well. ठीक है? Hopefully that's clear. ठीक है? तो यही छोटी छोटी गलतियां होती है बेटा. That has to be avoided in the examination. Nothing else. बड़े questions में गलतियां हो does not matter. छोटे questions में नहीं होनी चाहिए. Answer चलो. What is this? Here you are able to see beta there is an 8-year-old child. Okay, we have an 8-year-old child who presents to you with complaints of hearing loss. ठीक है? There is no prior history of any ear discharge or any pain or any kind of surgery for that matter. Otoscopic examination which is there beta of the tympanic membrane has been given below. Likely diagnosis of the child is no history, negative history beta. Very good, shabash. So if there is no history of any kind of infection, any kind of surgery, any kind of ear discharge, still the child is having hearing loss, and the otoscopic examination shows you a very classical picture beta. And what is that classical picture? Moti जैसा कुछ दिख रहा है ना? So here there is nothing as but a pearly white mass beta. So there is nothing as but a pearly white mass in the middle ear. ठीक है? Or behind an intact tympanic membrane. Tympanic membrane is also not inflamed beta. There is no infection over here. No inflammation is there. So pearly white mass behind an intact tympanic membrane beta in a child is usually suggestive of option A बच्चे, and that option A is nothing else but congenital cholesteatoma. That condition is nothing else but a congenital. Since birth itself beta there was a cholesteatoma present inside the patient's middle ear that kept on growing with time, and now when it has grown big in size, it has started causing hearing loss in the child beta. That is a classical case of congenital cholesteatoma. Clear? Everything normal except pearly white mass behind the intact tympanic membrane. Clear? Now, if I talk about the next option beta, that is tympanosclerosis. This is what a tympanosclerosis looks like beta. What is basically tympanosclerosis? So, sclerosis we know it is nothing else but fibrosis beta. So, when there is fibrosis or calcification of the tympanic membrane, can you see over here? So, there is fibrosis, there is scarring of the tympanic membrane beta. This condition is known as tympanosclerosis. So, scarring, fibrosis or calcification of the tympanic membrane is known as tympanosclerosis. Do remember the image beta, image is important. Just a spot diagnosis. This happens usually whenever there is infection of the tympanic membrane, and when that infection of the tympanic membrane heals, but that healing occurs with fibrosis or scarring beta, that leads to a condition called as tympanosclerosis. Clear? So that is important. Next one is this beta over here. What is this classically? Here we are able to see beta again a pearly white mass. Okay, and we know pearly white mass which is there beta, it is usually a cholesteatoma. Basically, what is cholesteatoma? Anybody? So again I am able to see beta motiu jaisa pearly white mass is there. So we know beta cholesteatoma it is again, but this is actually a case of because I am not able to see any kind of ear discharge beta, and this cholesteatoma is formed in the upper part of the middle ear. So this seems to be a case of a primary acquired cholesteatoma. Now what is this? Basically let's try to understand it, and please remember beta a primary acquired cholesteatoma which is there is the most common type of cholesteatoma also. So try to understand it basically beta. What happens? See, if the eustachian tube of a patient gets blocked beta, we know what the eustachian tube is going to maintain the air pressure of the middle ear as well beta. So middle ear has only one entry point, and that is the eustachian tube. Therefore, the eustachian tube has a function of maintaining the air pressure in the middle ear. But in case beta, if the eustachian tube of the patient is blocked, due to any reason, if the eustachian tube of the patient is blocked beta, then obviously we have to remember what will happen when the outer pressure will become positive beta. Still, as the middle ear is closed cavity now, the pressure inside the middle ear will keep on getting negative beta. The pressure in the middle ear will get negative, and as the pressure in the middle ear is negative now, therefore a vacuum, a suction will be created, and due to that vacuum or suction beta, the tympanic membrane will get pulled inside. Due to that beta, there will be retraction of tympanic membrane. There will be so much retraction of tympanic membrane that ultimately the tympanic membrane ruptures. And when, okay, so initially there is retraction of tympanic membrane in the upper part, usually pars flaccida. That retraction is so much that it forms a retraction pocket, and ultimately the tympanic membrane ruptures. When the tympanic membrane ruptures beta, the skin of the external ear beta, that skin of the external ear grows inside the middle ear cavity. And when the skin of the external ear grows in the middle ear cavity beta, that is what is called as a cholesteatoma. Yes. So basically cholesteatoma is nothing else beta but the ectopic skin in the middle ear. Now normally we know that middle ear mein we only have mucosa beta. But if this skin is going to grow inside the middle ear, that skin is what is called as a cholesteatoma. Samjhe baat? So that is important. Now do remember that most common type of cholesteatoma is primary acquired cholesteatoma, which happens due to blockage of the eustachian tube, too much retraction of tympanic membrane and rupture of tympanic membrane, which leads to growth of EAC skin in the middle ear. So important is that cholesteatoma also has bone eroding properties, and as cholesteatoma has bone eroding properties beta, therefore it damages the walls of the middle ear, and as it damages the walls of middle ear beta, the infection of middle ear may spread outside also, and that can lead to unsafe CSOM in the patient as well. Okay, that may lead to unsafe CSOM as well in the patients. Okay, so unsafe CSOM or unsafe chronic suppurative otitis media is usually due to a cholesteatoma, because cholesteatoma has bone eroding properties, due to which it damages the wall of middle ear and the infection spreads outside the middle ear, causing multiple complications. Okay, please tell me what is the most common site for a cholesteatoma. Anybody? It is in the upper part of the middle ear called as epitympanum. But what is that space called as? The space between the malleus and the pars flaccida beta in the middle, in the upper part of the middle ear. This space out here between the pars flaccida and the malleus beta in the upper part of the middle ear is basically called as, it is classically called as the Prosac space beta. Do remember this one liner? This is known as the Prosac space. Very good. So Prosac space is considered as the most common site for a cholesteatoma. Prosac space is considered as the most common site for a cholesteatoma beta in the epitympanum or the attic. Clear? Shabash. Next important beta is this condition out here. Here the patient is going to have beta a very classical feature. My patient will come to me. She is a female beta who comes to me. She is a female who comes to me with a pulsatile tinnitus. What is pulsatile tinnitus? She is having beta a ringing sensation. Instead of ringing sensation in the ear, she is able to feel, she is able to hear pulsations of a vessel beta. So that is called as a pulsatile tinnitus. Okay? And my patient is having a mild conductive hearing loss. My patient is also suffering from a conductive hearing loss. So pulsatile tinnitus along with conductive hearing loss and this kind of a picture on otoscopy beta. This kind of a classical picture on otoscopy. What is this sign called as basically? Pehle ye batao. What is this sign called as? On otoscopy, you are able to see this classical red vascular mass growing from the lower part or growing from the floor of the middle ear beta in the hypotympanum or in the lower part of middle ear. This sign is classically referred to as the rising sun sign, bache. This sign is classically referred to as the rising sun sign. Okay? So this is the classical rising sun sign which is seen in the patient, and this is usually seen in a patient suffering from glomus jugulare beta, also known as glomus tympanicum. It is usually seen in a patient who is suffering from glomus jugulare, also known as glomus tympanicum. So do remember beta, in the previous year examination, instead of glomus jugulare, the another option which was given was glomus tympanicum. Reason is beta, I told you that this tumor usually grows inside the middle ear cavity, and middle ear is also known as tympanum. Therefore, this can also be referred to as glomus jugulare or glomus tympanicum beta. Now here we know it is a highly vascular tumor beta. For example, this is the, okay, this is definitely the sigmoid sinus. This is definitely the jugular bulb beta. So it usually arises from the glomus cells of the jugular bulb, and therefore the tumors grows inside the middle ear cavity beta. Okay, this is what is classically called as the glomus jugulare. Please tell me here. Now, what is the investigation of choice beta? Patient is a female coming to you with pulsatile tinnitus, conductive hearing loss, sometimes a red bleeding mass or a rising sun sign on otoscopy. Okay. What is the investigation of choice? Will you go for a biopsy in this patient? Will you go for a biopsy in this patient? Very good. So please remember beta, very good. Shabash. So investigation of choice in the patient is nothing else but a CECT scan beta. So CECT scan. Okay, contrast enhanced CT scan is the investigation of choice, and on that, very good, a Phelps sign is seen. Phelps sign is nothing else but erosion of the septum between the carotid canal and the jugular foramen. That is what is known as a Phelps sign beta. So CECT scan is the investigation of choice and Phelps sign is usually seen on that. Do remember that biopsy is absolutely contraindicated in the patient. Reason is this is a highly vascular tumor beta. Therefore the patient may bleed to death if you go for a biopsy. The treatment of this condition, if they ask you beta. So treatment of this condition is surgical excision. Now you will be like, so you are not even saying us to take a biopsy and now you are going for a surgery. Won't that tumor bleed a lot? So for that beta, prior to surgery we have to do some preparation. And what is that preparation? Before the surgery, pre-operatively, you have to go for an embolization beta. Pre-operative embolization has to be done. That is blocking the main blood supply of the tumor beta. If you block the main blood supply of the tumor itself beta, therefore when you remove the tumor or when you surgically excise the tumor, the bleeding is going to be minimal beta. So do remember that the treatment has to be surgical excision, but prior a pre-operative embolization has to be done. Shabash. Clear? That is important about all the points that were to be discussed. Bodo. Now this is the question that all of you have thought about earlier. So here we have a question which states a patient presented to the OPD beta and was having a mild hearing loss, okay? And the ear was impacted, ear wax was impacted in the EAC beta, and intern was asked, okay? And intern was asked to perform ear syringing. The patient suddenly collapses, the patient suddenly collapses after the procedure. What is the likely cause of the condition? Very good. Now that is important, shabash. The likely cause of this condition has to be, so whenever a patient has excessive amount of ear wax beta, whenever the patient has excessive amount of ear wax, do remember the treatment of ear wax which is there beta. Ear wax is produced by the ceruminous glands of external auditory canal. Excess production of ear wax may lead to blockage and the patient may experience some heaviness in the ear. Pain nahi hota beta usually, but heaviness in the ear and conductive hearing loss is there. For that, the treatment which is there beta, it is ear syringing. Now we know that whenever a patient has to do a ear syringing, two things he has to keep in mind beta. Okay, so whenever you have to do a ear syringing, keep two things in mind. First, the direction of ear syringing should always be postero-superior beta. Okay, the direction of the syringe should always be postero-superior, it's upwards and backwards. Okay, and second important thing which is there beta is the syringing which is there beta. For the purpose of syringing, we should always use warm water or warm saline. So warm water or warm saline has to be used beta for the purpose of ear syringing always. Clear? So that has to be kept in mind. Agar tum ye nahi karte ho, what is going to happen due to that reason now? First, if you use cold water beta, if cold water has been used instead of warm water, which is cold water, then what happens beta, suddenly the temperature of external auditory canal changes, and due to that beta, due to that sudden temperature change, the lateral semicircular canal of the patient gets stimulated, and whenever there is any disturbance in the lateral semicircular canal or any of the semicircular canal, patient will always have a disturbance in the angular balance of the body. We know that semicircular canals are responsible for the angular balance of body. Important question, okay? So whenever there is disturbance in those semicircular canals, patient will have a disturbance in angular balance causing a spinning sensation, chakkar aate, that is vertigo. So if definitely beta cold water has been used, the patient is going to experience vertigo, which is that has to be remembered. And second, if the direction of ear syringing is antero-inferior. Now, I told you the direction should be postero-superior beta. But if the direction of ear syringing is antero-inferior, then you are actually going to push, then you are actually going to put a lot of pressure on the floor beta, and therefore the floor or the inferior wall of the EAC gets irritated. And we know the floor or the inferior wall of EAC is usually stimulated, the floor or the inferior wall which is there beta, okay, that is usually supplied by the auricular branch of vagus nerve. And this auricular branch of vagus nerve which is there beta, it is called as the Arnold's or the Eiderman's nerve. Okay, it is known as the Arnold's or the Eiderman's nerve beta. So there is going to be a Arnold's or Eiderman's nerve irritation, and as this Arnold's or Eiderman's nerve has been irritated beta, even the parent nerve, that is the vagus nerve, gets irritated. And as the vagus nerve has been irritated, that's the reason the patient is going to have two important things. We know that vagus nerve also supplies the throat of the patient beta, the superior and the recurrent laryngeal nerve. Those are branches of vagus nerve. So as the vagus nerve gets irritated over here beta, you are going to see the problem over here also in the throat, and that is the patient is going to have a cough reflex beta. The patient is going to experience a cough reflex. Second important, as the vagus nerve, we know beta, it's a parasympathetic nerve. As it is a parasympathetic nerve beta, as it will get activated, there will be parasympathetic overactivity. The heart rate of the patient decreases, causing bradycardia. There is decreased blood supply to the brain. Second, a lot of blood is usually sent towards the GIT beta, because whenever vagus nerve is activated, there is vasodilatation of the GIT vessel. So a lot of blood goes towards the GIT. Due to these two reasons, there is decreased blood supply to the brain beta, and when brain receives decreased blood supply, the patient will usually go into a syncope beta, that is called as vasovagal syncope. Due to irritation of vagus nerve, there is vasodilatation causing a vasovagal syncope beta. Okay, when the patient collapses. Okay, so here in this patient beta, it was a case of vasovagal syncope itself, because after the ear syringing beta, the patient suddenly collapses. They have mentioned in the question itself. Okay, so patient suddenly collapses after the procedure. So it is likely to be a case of vasovagal syncope. Bolo abhi kya hoga? What is the cause? So we know now answer has to be option C beta, that is irritation of the Arnold's nerve. Use of cold water will lead to vertigo. Irritation of nerve of Wisberg beta, it's not seen over here, it's seen in it is usually seen in acoustic neuroma beta when there is damage to the nerve of Wisberg, not irritation. Direction of ear syringing is posterior-superior, that has to be posterior-superior, हमने वही तो बोला था. Clear? So answer has to be option C, irritation of Arnold's nerve beta. Okay? So you can see the floor and the roof. So the floor and the posterior wall of the EAC beta is supplied by the auricular branch of vagus nerve, that is your Arnold's nerve beta. Second, the roof and the anterior wall. The roof and the anterior wall is supplied by the auricular temporal nerve, which is a branch of the mandibular nerve. Okay? And the posterior-superior part of EAC, the yellow one that you can see, it is supplied by the sensory division of facial nerve. This is known as the nerve of Wisberg beta. Clear? This is known as the nerve of Wisberg. Hopefully that's clear to all of you now. Chalo. And यहाँ और एक बात याद रखना, you can see the whole of the pinna beta, majority of the pinna is blue in color beta. So if they ask you what is the main nerve supply of pinna beta, if they ask you main nerve supply of pinna, answer has to be a greater auricular nerve. Do remember, the main nerve supply of pinna is greater auricular nerve. Another question I'll ask from here, if you by mistake damage the greater auricular nerve beta, if you by mistake damage the greater auricular nerve during a surgery, what is the problem that the patient is going to face? This was a previous year question of your exam. If the greater auricular nerve gets damaged beta, what is the problem the patient may experience during the surgery? Sorry, after the surgery. Important PYQ. If there is damage or injury to the greater auricular nerve, what is the problem that is going to happen in the patient? Very good, shabash. Important is they will usually say beta, after the surgery, while the patient is sheathing, there is loss of sensation or there is anesthesia beta. The patient is not able to feel any sensations while sheathing, usually over the angle of mandible or the angle of jaw beta. Over the angle of jaw, there are no sensations felt. Okay? Because this greater auricular nerve carries sensations from here. Okay? So injury to greater auricular nerve leads to loss of sensations or anesthesia. Okay? Over the angle of jaw or the angle of mandible. Clear to all of you now? That has to be remembered. Shabash. Okay? So that is important to be remembered beta. That has to be remembered. It is a sensory nerve which is going to carry the sensations from you. Shabash. Next important question number 9. Bolo. Here we have a question which states beta, a patient of neurofibromatosis type 2, that is NF type 2, was complaining of bilateral gradually progressive hearing loss beta. The PTA or the pure tone audiometry which is there beta, it reveals a 100 decibels of hearing loss. The pure tone audiometry reveals 100 decibels of hearing loss in both the ears beta. Bilateral 100 decibels of hearing loss. We know if the hearing loss is more than 90 decibels beta. If the hearing loss is more than 90 decibels, that is called as a profound hearing loss. So this patient is going to have a bilateral profound hearing loss beta. More than 90 decibels of hearing loss is profound hearing loss bache. The hearing aid, okay, the hearing aid is planned to be used. Where shall we place the electrode beta of that hearing aid? Where should we place the electrode of that hearing aid? Bolo. Are you sure? Pakka? So do remember beta, here the most important history which is there, where normally whenever the patient has a profound hearing loss beta, whenever the patient has a profound hearing loss, this is the hearing aid to be used. Okay? So whenever a patient is going to have a bilateral profound, whenever the patient is going to have a bilateral profound sensory neural hearing loss, okay, this is the kind of hearing aid that we have to use beta. And what is that? Here the hearing aid is directly going to stimulate the cochlea beta. So here definitely it is called as a cochlear implant surgery. Here it is classically called as a cochlear implant surgery beta. Now important is the hearing aid of choice in a patient of bilateral profound sensory neural hearing loss is cochlear implant surgery. And in cochlear implant surgery, yes, a electrode goes beta inside the cochlea and directly stimulates the cochlea. Now when the electrode goes and stimulates the cochlea beta, where is the electrode actually placed? So in cochlear implant surgery, your answer is right, that is placed in the scala tympani. Okay, so it is placed in the scala tympani of the cochlea beta, okay, in cochlear implant surgery. But what is the condition for a cochlear implant surgery beta? What is the prerequisite that should be fulfilled? What is the condition that should be fulfilled? A condition for a cochlear implant surgery has to be, क्या है? क्या होना चाहिए? What is the mandatory condition? The eighth nerve of the patient should be damaged or normal? Eighth nerve of the patient should be damaged or normal? Eighth nerve should be damaged or normal? The eighth nerve should be absolutely normal beta, it should be intact. Yes, the eighth nerve of the patient should be absolutely normal, that means it should be intact. Reason beta, याद रखना ये बात, if you say beta, you are stimulating the cochlea and then the signal has to be carried further via the auditory pathway. What is the part of our auditory pathway beta? We know it is E. coli ma. What is E. coli ma? Eighth nerve, cochlear nucleus, superior olivary complex, lateral lemniscus, inferior colliculus, medial geniculate body and auditory cortex. Now you are stimulating the cochlea, that's fine. But eighth nerve, if it is damaged beta, will the signals get carried further? Obviously not. ठीक है, करते रहो cochlea को stimulate beta. Okay, the eighth nerve, if it is damaged, the signals will not get carried further. So that's a condition beta which should be fulfilled for a cochlear implant surgery, that the eighth nerve of the patient should be absolutely normal. Then only the signals can be carried beta, and then only a cochlear implant surgery can be useful. But if I say that the but if I say the eighth nerve is itself damaged, अगर मैं ये बोलता हूँ बेटा the eighth nerve has been damaged, will a cochlear implant surgery be useful? If the eighth nerve has been damaged, will a cochlear implant surgery be useful? Bolo. So obviously here the cochlear implant surgery is not useful, and that is the same case in your question beta. Reason, because your patient is suffering from NF type 2, and I hope all of you are quite aware, if a patient is suffering from neurofibromatosis type 2 beta, neurofibromatosis is a neurocutaneous syndrome, and the most common tumor associated with neurofibromatosis type 2 is a acoustic neuroma, also called as a vestibular schwannoma beta. Now we know that usually acoustic neuroma or vestibular schwannoma, which is your eighth nerve tumor, that is mostly unilateral. Okay? Acoustic neuroma or vestibular schwannoma is usually unilateral, except in one condition, and that is neurofibromatosis type 2. Because in neurofibromatosis type 2 beta, there is a bilateral acoustic neuroma in the patient. And if I say the patient is having a bilateral acoustic neuroma, due to that, both the 8 nerves of the patient has been damaged. And if both the 8 nerves are damaged beta, due to that reason, the patient is having a bilateral profound sensory neural hearing loss. Due to this reason beta, the patient is having a bilateral profound sensory neural hearing loss. Obviously, as there is a tumor in both the 8 nerves beta, both the 8 nerves of the patient have been damaged over here. And now if 8 nerves are damaged, will a cochlear implant surgery be useful? Obviously not. Okay, so here the cochlear implant surgery will not be useful. So definitely we cannot go for a cochlear implant. So scala tympani, scala vestibuli will be out of the options beta. Vestibule is any which way is not responsible for hearing. Okay, so it has to be option B, lateral recess of the fourth ventricle. Why? Reason is beta, here we have to use a hearing aid beta. Here we have to use a hearing aid which is directly going to stimulate the brainstem. Can you see? Here we have to use a hearing aid where the electrode goes and directly stimulates the brainstem beta. And which part of the brainstem? If the 8 nerve is damaged, the next part of the auditory pathway is the cochlear nucleus, not cochlea, cochlear nucleus. So in the brainstem area beta, it directly goes and stimulates the cochlear nucleus, that electrode, and therefore the patient is able to hear beta. This kind of implant is what is known as ABI beta, and that ABI is nothing else but auditory brainstem implant. That ABI is nothing else but a auditory brainstem implant. Okay, this is a very common question of your exam, and every time people make mistakes, so do not expect it this time. ठीक है, तो इस बार mistake नहीं करनी है in case this question repeats. ठीक है, तो auditory brainstem implant beta, and here the electrode, as I told you, is usually placed in the lateral recess of the fourth ventricle beta. The electrode which is there, it is inside the lateral recess of fourth ventricle. Clear to all of you? Chalo. This is the normal hearing aid that we use beta, called as a behind the ear hearing aid. So this is the commonly used behind the ear hearing aid. Rather, this is the most commonly used hearing aid beta, behind the ear hearing aid. Cheap also, easy also, no problems it causes. Okay? Next important is this out here beta. And what is this over here? Here you are able to see beta, a hearing aid which is directly attached to the skull bone. What is done? A titanium screw has been attached to the bone beta, and just on that titanium screw we have to fix this hearing aid. Now if the hearing aid is directly attached to the bone beta, that is called as a baha. If the hearing aid is directly attached to the bone, that is known as baha. And what is baha? Bone anchored hearing aid beta. Bone anchored hearing aid is what is known as baha. What are the conditions where we are going to use baha in the patient? Anybody? Very good, shabash. So baha which is there beta, it is generally used when the pinna is not developed, okay, or it is underdeveloped. The reason is beta, most of the hearing aids we have to attach one component of that hearing aid to the pinna itself. But agar kisi mein pinna hi nahi hai, if some patient is not having pinna, that is called as anosia beta, or some patient is having a small and underdeveloped pinna called as microtia, in those patients we have to use baha beta. Apart from that, the indications which is there beta, if any patient is having EAC atresia, that is the external auditory canal of that patient is not developed beta, or it is very very small or very very narrow beta, that is EAC stenosis. So EAC atresia or EAC stenosis bache, or the patient is going to have a chronic ear discharge beta, or the patient is going to have a chronic ear discharge. So in these four conditions beta, do remember that baha will be the hearing aid of choice. Okay, in these four conditions do remember that baha is going to be a hearing aid of choice. Clear? Koi dikkat? So do remember these four hearing aids. Chalo. Answer the next question, question number 10 bache. If I talk about this question number 10 over here, what is the question saying? It says, very classical and sarkari question, as I always say. Here they say beta, a neonate was brought to you by parents with complaints of noisy breathing. Okay? And we know noisy breathing is usually known as a stridor. So here they are saying the patient is having a stridor beta. So neonate is having a stridor beta. On examination the stridor increases. On examination the stridor increases when the child either cries or lies in the supine position beta, and decreases whenever the child lies in the prone position. Laryngoscopy reveals a floppy epiglottis. Floppy matlab loose, dhila. Okay, so laryngoscopy reveals a floppy epiglottis bache. What is the best treatment option for this child? What is your provisional diagnosis? What is your provisional diagnosis for this condition? Very good. The provisional diagnosis for this condition is a case of laryngomalacia beta. Now what do I mean by malacia beta? Malacia is softening or weakness. So here there is weakness of the larynx beta since birth itself. Okay, so it is a congenital anomaly. Rather, it is the most common congenital anomaly of larynx beta. Yes, this condition known as laryngomalacia is the most common congenital anomaly of larynx. First point to be remembered. Second beta, as here the larynx is going to be weak, especially the supraglottis beta or the epiglottis. What happens? See, this is the larynx of the patient. This is the epiglottis which is there. Normally epiglottis is leaf shape beta, it closes, it opens properly, but here the epiglottis is weak beta, and as the epiglottis is weak, it falls down. As it falls down over here beta, therefore it is going to close the larynx, and as it causes closure or as it causes obstruction in the larynx beta, we know obstruction of the airway will lead to that noisy breathing called as the stridor. If there is obstruction in the pharynx or the supraglottis beta, hopefully all of you are quite aware, if there is obstruction in the pharynx or the supraglottis beta, which kind of stridor is heard? We are able to hear definitely a inspiratory stridor which is. If there is any obstruction in the glottis, in the subglottis or in the cervical trachea beta, okay, then definitely we are able to hear a biphasic stridor which is, that is noise will be heard during inspiration as well as expiration. Okay, and third important beta, if there is any obstruction in the thoracic trachea, okay, or the bronchi beta, if there is any obstruction in the thoracic trachea or bronchi, patient is going to have an expiratory stridor that is only heard during expiration. That is important to be remembered beta, do remember this. So obstruction of the airway always causes stridor. Now that obstruction can be due to anything, foreign body, weak epiglottis, edema, whatever is the reason beta, always leads to a stridor. So yaad rakhna that laryngomalacia is the most common cause of stridor in neonates beta. It is also the most common cause of stridor in neonates. So if they ask you what is the most common cause of stridor in neonates, answer has to be laryngomalacia itself beta. Clear? So that is important. And here there is a very classical feature. As the child lies supine beta, the epiglottis closes the larynx and therefore the stridor increases. But as the child lies in prone position beta, पेट केवल जब से बच्चा सोता है, the epiglottis falls back and therefore the larynx opens up more properly and therefore definitely the stridor decreases. This is a very classical feature. If they ask you beta in laryngomalacia, which type of a stridor is heard? This was a recent question of your exam. Okay? Which type of stridor is heard in laryngomalacia? Bolo. Which is the type of stridor to be heard in laryngomalacia? Inspiratory, biphasic, expiratory. Inspiratory, biphasic, expiratory. Which is the type of stridor to be heard in laryngomalacia? Bolo. It is nothing else but an inspiratory stridor. Reason, the problem is inside the supraglottis beta. It is usually seen in the supraglottis. As the epiglottis is closing the supraglottis beta, the patient is going to have an inspiratory stridor. Very good. This is an important thing to be remembered. Recent question of your exam. Okay? Next important beta, here you are able to see when you do an examination. On examination, this is the classical picture that will be seen. On examination, you are able to see as the epiglottis is weak beta, the epiglottis falls down and it looks like a omega beta. Ohm sign nikala hoga na physics mein. So it looks like this omega which hai. So omega shaped epiglottis which is there beta, it is usually seen. There's a omega shaped epiglottis which is classical. But मैंने इसीलिए दूसरा term use किया बेटा, just to make you sure that at times they may use the term floppy also. Floppy का मतलब होता है weak, right? So do remember that. So omega shaped epiglottis or a floppy epiglottis or a loose epiglottis, whatever the term used is beta, the answer is going to remain the same. Okay, shabash. That is important. And we know beta in this condition the treatment is nothing else but option D, reassurance to parents. Reason beta, this is a self-resolving or a self-limiting condition. As it is a self-limiting condition beta, the child does not need any treatment. Just with time beta, the condition is going to get resolved. So it is a self-limiting condition and it is going to resolve by a span of 2 years beta. It is usually going to get resolved within a span of 2 years. Even after 2 years, if it is not resolved, then what we have to do? Even if after 2 years beta, the condition persists. Even after 2 years, the stridor persists. If the condition stays, then we have to go for repair of the supraglottis beta. and that is what is known as a supraglottoplasty, or we have to fix the epiglottis, that is called as a epiglottopexy. So after 2 years still if the patient shows no improvement, then we have to go for a supraglottoplasty or an epiglottopexy beta. Okay, so either of that has to be marked your answer. Very good. Okay, no issues with this anybody. Supraglottoplasty is done after 2 years of age. Laryngotracheal reconstruction is a treatment that is done for subglottic stenosis. When there is narrowing of the subglottis beta in grade 3 and grade 4 subglottic stenosis which is there beta, we have to go for a LTR, that is called as laryngotracheal reconstruction. CO2 laser excision can be done for vocal cord problems beta. Okay, so hopefully that's clear to all of you now about laryngomalacia. Okay, chalo. Shall I take a just 2 minutes break beta? There is a problem, I just need to attach the charger, so just 2 minutes break and then I'll just be back. Just a 2 minutes break. चलो shall we start? Okay, so now here we have a question which states beta, patient underwent a superficial parotidectomy. Okay, a superficial parotidectomy beta, that is removal of the superficial lobe of the parotid gland for a pleomorphic adenoma. Hopefully all of you are quite aware that pleomorphic adenoma is the most common salivary gland tumor or the most common parotid gland tumor beta, याद रखना है नाम. ठीक है, few months later the patient complains of facial sweating and skin flushing beta whenever he eats food. Okay, whenever the person eats food beta, as shown in the picture. ठीक है, so whenever the person eats food, definitely he is having sweating and flushing. Which nerve injury is responsible for his condition? Which nerve injury is responsible? Very good, shabash. So now what happens is, try to understand. We know beta, this is the parotid gland and this is the cheek beta. Okay, We know that parotid gland has 3 nerves beta in it. First nerve which is there, it is the main nerve supply of the parotid gland, and the main nerve supply of the parotid gland is your 9th cranial nerve, also known as your glossopharyngeal nerve. Okay, 9th cranial nerve or glossopharyngeal nerve is the main nerve supply of parotid. Second is the nerve which gives secretomotor fibers to parotid gland. What do I mean by this? So whenever the patient is going to eat food beta, this nerve will stimulate the parotid gland, and in response to which the parotid gland is going to release saliva beta. That is called as a secretomotor supply. And third is the gland beta, which has a relation with parotid gland, and that nerve is which says I love you but only as a friend beta. ऐसा रिश्ता किसके साथ होता है parotid gland का? Let me know in the chat box. ठीक है, let me know in the chat box. The nerve which says I love you but only as a friend, which goes inside the parotid but does not give any branch to the parotid gland beta. ठीक है? So that is important. So now here what happens is beta, for example, this is the auriculotemporal nerve. Now this auriculotemporal nerve, we know beta, it gives secretomotor fibers to the parotid gland. So now here during a superficial parotidectomy surgery beta, the auriculotemporal nerve may get damaged, and when the auriculotemporal nerve gets damaged beta, there is definitely a recovery, but this time the auriculotemporal nerve undergoes abnormal recovery beta, and instead of supplying the parotid gland, now it may start supplying the sweat glands over the skin beta. Okay, it may start supplying the sweat glands over the skin. Now what is going to happen? See, okay, we know bache that whenever you are going to eat food beta, whenever you are going to eat food, okay, the nerve which is going to get stimulated is the auriculotemporal nerve, and it is going to stimulate the parotid gland for salivation. But this time it will stimulate parotid, but a lot of abnormal fibers which are there beta, these abnormal fibers may also stimulate the sweat glands, and due to that beta, the patient may start sweating, or there is vasodilatation which causes redness or flushing beta on the cheek in this patient. And this is a classical case of which syndrome? This is a classical case of a Fraze syndrome bache. So here the provisional diagnosis of the patient is a classical case of Fraze syndrome. We know that Fraze syndrome is also called as gustatory sweating. Fraze syndrome is also known as gustatory sweating. Why? Because whenever the patient eats food beta, especially spicy food, patient has a lot of sweating, or a patient has a lot of flushing beta on the cheeks or on the in the temporoparietal area. Therefore, this is what is classically a case of Fraze syndrome beta. As you are able to see, a lot of redness and sweating beta. This is due to injury or abnormal recovery of which nerve beta? We know this is due to injury or abnormal recovery of the auriculotemporal nerve. You can even give beta locally injection of botulinum toxin, and that local injection of botulinum toxin is going to kill all these nerve fibers beta which have abnormally grown, and therefore that can treat this condition as well. So Fraze syndrome ke liye the treatment can be an injection of botulinum toxin also. Okay? I've told you about greater auricular nerve. When that gets injured, patient has loss of sensations over the angle of mandible. Chorda tympani nerve, if it is injured beta, please tell me what will happen if the chorda tympani nerve gets injured. We know chorda tympani nerve injury is usually seen in the floor of mouth surgeries. In floor of mouth surgeries beta, or in ear surgeries also, at times the chorda tympani nerve may get damaged, and if there is a damage or injury to the chorda tympani nerve, what the patient will have? So do remember, patient will have loss of which sensations beta? Taste sensations or general sensations? Patient is going to have bache loss of taste sensations. From which part of the tongue? Anterior 2/3 or posterior 1/3? There will be loss of taste sensations from anterior 1/3 or posterior, anterior 2/3 or posterior 1/3? Very good. From the anterior 2/3 of the tongue beta. Shabash. So please remember, there will be loss of taste sensations beta from the anterior 2/3 of the tongue. Okay, so loss of taste sensations from anterior 2/3 of the tongue is going to happen if the chorda tympani nerve, which is a branch of facial nerve, if that gets injured. Okay? Now in floor of mouth surgeries itself beta, for example in granular surgeries, another nerve that gets injured, or rather the most common nerve injured in floor of mouth surgeries, I have told you that in floor of mouth surgeries, the most common nerve injured, anybody? Most common nerve injured in granular surgery or in floor of mouth surgery beta. Most common nerve injured in the floor of mouth surgeries. I'll wait for this answer. This is an important question. Most common structure injured in floor of mouth surgeries is the submandibular duct beta. It is the submandibular duct. But if they ask you which is the most common nerve injured in floor of mouth surgery, then what is your answer? Very commonly repeated question. August का भी question रह चुका है ये. Okay. So most common nerve injured in floor of mouth surgeries beta. Very good, shabash. It is a lingual nerve. We know that lingual nerve is a branch of the mandibular nerve itself beta. It is a lingual nerve. Okay. So lingual nerve is very commonly injured beta, and if I talk about lingual nerve injury, we know if the lingual nerve gets injured beta, patient has loss of general sensations, that is pain, touch, temperature and pressure beta. So there is loss of general sensations from anterior, okay, loss of general sensations from anterior 2/3 of tongue. There is loss of general sensations from the anterior 2/3 of tongue beta. Hopefully that's clear. Chalo, ठीक है? No issues with this. So do remember these beta. These are important again. याद रखना सर्जरी से a very important complication is nothing else except the nerve injuries बेटा. Yes, nerve injuries जिस भी condition में या किसी भी surgery में दिखवाइए बेटा, that becomes an important question for you because that's a probable question which has been asked in the examination. ठीक है? Easy question. सरकारी. ठीक है? Which sinus is never visible? Which sinus is never visible beta on the below given X-ray of paranasal sinus? On the below given X-ray of the paranasal sinus. Maximum beta around 9:15 it would be. Because I have a session from 10 for one-liners also. Very good. What is the view of the X-ray? So here definitely this is the X-ray paranasal sinus beta, and this view is what is called as the water's view beta. This view, it seems as if the patient is looking upwards and drinking water ना, तो याद रखना ऐसा view अगर दिखता है, so that is called as a water's view of the X-ray paranasal sinus beta. And this water's view is also known as the occipitomental view बच्चे. Water's view is also known as the occipitomental view. Now water's view is of two types beta. Either it can be an open mouth water's view or a closed mouth water's view beta. Yes, either it can be a open mouth water's view or a closed mouth water's view. Closed mouth water's view do not have any special name, but yes, open mouth water's view do have a special name. Anybody, what is the name of the open mouth water's view? What is the name of the open mouth? Shabas. It is a Pierce view beta. So do remember the open mouth water's view which is there. It is also known as the Pierce view. That has to be remembered. Okay? So it is the Pierce view which is seen over here because it is a open mouth water's beta. So it can also be called as a Pierce view. Okay? That has to be remembered. Now, in this condition beta, do remember here you are able to see that the frontal sinus is visible. Okay? Definitely here the patient will have the anterior ethmoidal air cells, anterior ethmoidal air cells which are visible beta. Okay, this maxillary sinus is visible over here. Even the sphenoid sinus will be visible because the patient has opened up the mouth beta. But one sinus which is never visible, beta, and that has to be option D, posterior ethmoidal air cells. All the other sinuses will be visible on the water's view beta except the posterior ethmoidal air cells. They are never visible on a water's view beta or even on a Pierce view. That has to be remembered. Can anybody tell me what is that X-ray of paranasal sinuses where all the sinuses are visible beta? What is the X-ray of paranasal sinuses beta where all the sinuses are visible? Where all the sinuses are visible. कौन बोला बेटा फ्रंटल एब्सेंट? ये सामने दिख नहीं रहा अपने को. एक्सरे में सामने है ना, ये देखो. ये कौन सी साइनस है बेटा फ्रंटल बोन में तुम्हारी? What is this sinus over here? This is the frontal sinus itself ना. कैसे बोल सकते हैं हम frontal absent है? Is the posterior ethmoidal air cells which will not be visible. ठीक है, very good, शाबाश. It is the X-ray skull lateral view बेटा. This one which is there, the X-ray skull lateral view बच्चे, it is the one where all the sinuses are visible beta. Do remember that X-ray skull lateral view. So if they ask you what is that view of X-ray paranasal sinuses where all the sinuses are visible beta, answer has to be the X-ray skull lateral view. All sinuses are visible. Can you see over here? Just see, I'm highlighting again. So here you are able to see this is the frontal sinus out here beta. Okay, this is the ethmoidal sinus over here. Okay, the posterior as well as anterior ethmoidal air cells both are going to be visible. Here this is the maxillary sinus which is visible. Clear? And here behind this is the sphenoid sinus which is visible beta. यहाँ पे ये पूरा ethmoid sinus है and this is the sphenoid sinus and the body of sphenoid. Clear? So can you see all the 4 sinuses are visible over here? So if they ask you beta that which is the only view of X-ray paranasal sinuses where all sinuses are visible, so answer has to be a X-ray skull lateral view. All sinuses are visible over here. All sinuses are visible over here, which is clear. So that has to be remembered. Shabash. No issues with this. This one is the Waters view. I've already told you beta. This one which is there. Here it seems as if the patient is looking in front beta. Actually the patient is looking at an angle of 10 to 15 degrees lower beta. The patient is looking at an angle of 10 to 15 degrees downwards. But it seems on the X-ray as if the patient is looking in front. And this is what is called as a Caldwell's view, bache. This is classically called as the Caldwell's view of X-ray paranasal sinuses. And this Caldwell's view of X-ray paranasal sinuses is also known as the occipitofrontal view beta. This Caldwell's view of paranasal sinuses is also known as the occipitofrontal view. Okay? So that is important. Now, one by one sinus beta. One by one sinus if I ask you. Please tell me which is the best view. Which is the best view beta for the maxillary sinus. Which is the best view for the maxillary sinus beta? Bolo. The best view for maxillary sinus is which X-ray view? Out of these 3 that we have discussed, which is the best view for maxillary sinus? So do remember in maxillary sinus beta, if they ask you which is the best view, so yaad rakhna, best for maxillary sinus which is there beta has to be the Waters view. Okay, so do remember यहाँ पे बहुत clearly दिख रही है ना. So please remember the best for maxillary sinus is the Waters view beta. That has to be remembered. Okay, which is the best view bache for the sphenoid sinus? Which is the best view for the sphenoid sinus beta? So do remember the best view for the sphenoid sinus, if they are going to ask you beta, it is going to be this one, X-ray skull lateral view. Yes, X-ray skull lateral view which is there beta, it is the best one for the sphenoid sinus. So if they ask you that which is the best one for the sphenoid sinus, so answer has to be the X-ray skull lateral view has to be the best one for sphenoid sinus. And if they ask you which is the best one for frontal and ethmoidal sinus, so do remember beta, the best view for the frontal as well as the ethmoidal sinus which is there beta, it has to be the Caldwell's view. The best view for the ethmoidal and the frontal sinus has to be the Caldwell's view. Hopefully that's clear to all of you now. No issues with this, anybody? Chalo. So these are the important things beta to be remembered about the X-ray paranasal sinuses. Next one. Important question beta, repeated quite often in your examination. Okay. So yes, Waters view pe, if the mouth is closed beta, do remember even open mouth Waters view, even Pierce view is a type of Waters view itself. Yes, the best specific answer can be Pierce view, but yes, obviously for the mouth, for the sphenoid sinus itself, you ask the patient to open the mouth beta. Clear? So that is important. Bolo, what is the answer over here? Here we have a question beta which states a patient underwent a surgery, a patient underwent a surgery over here. Okay, for removal of cystic mass beta, for removal of some cystic mass in the neck region, or post-operatively patient had aspirations beta, patient had recurrent aspirations without any change in the voice, without any change in the voice beta. Which is the likely nerve to be injured in the patient? What is the likely nerve to be injured in the patient? So now if I talk about the SLN beta, so what is SLN? Basically it is a superior laryngeal nerve. Now we know the larynx which is there beta, that larynx is usually supplied by 2 nerves beta. Okay, the larynx is innervated by or supplied by 2 nerves. One is definitely called as the SLN, that is superior laryngeal nerve, and second is called as the RLN, that is the recurrent laryngeal nerve. Recurrent, why? Because it goes inside the chest and comes back upwards in the neck. Okay, so these 2 are the nerves which are going to supply or innervate the larynx. Now out of that beta, both of these are branches of vagus nerve beta. Do remember, superior laryngeal nerve has 2 branches to it, bache. Superior laryngeal nerve has 2 branches to it. One is called as the internal branch of the superior laryngeal nerve, and this internal branch of superior laryngeal nerve can also be called as the internal laryngeal nerve or the ILN beta. Whereas another is the external branch of the superior laryngeal nerve, and this external branch of superior laryngeal nerve can also be called as the ELN, that is your external laryngeal nerve also. Now if they say beta, what is the function of the internal laryngeal nerve? So do remember beta that this internal laryngeal nerve which is there, it is going to give sensory supply. This internal laryngeal nerve which is there beta, it gives sensory supply to supraglottis. What is supraglottis? The area above the true vocal cords, or the area above the glottis is known as supraglottis in the larynx. So the sensory supply, that is sensations from the supraglottis, is carried by the internal laryngeal nerve. Okay. Whereas what is the function of the external laryngeal nerve? The function of the external laryngeal nerve which is there beta, it is going to supply the cricothyroid muscle. It is going to supply the cricothyroid muscle. Okay. And what is the main function of cricothyroid muscle? So please remember beta, the main function of cricothyroid muscle, it is actually a tensor muscle beta. What is tensor muscle? The muscles which are going to stretch the vocal cord beta, which are going to tense the vocal cord. Why? Because if the vocal cords are stretched out, if the vocal cords are tensed out beta, then definitely the quality of voice which will be produced will be a better quality of voice, right? So that's the reason the vocal cord should be stretched, and for that we have the cricothyroid muscle. So it is actually responsible for better quality of voice beta. It is going to be responsible for better quality of voice. Okay? Now in this condition beta, if I say, okay, if I say that if the patient's internal laryngeal nerve gets injured, if I say the patient's internal laryngeal nerve gets injured beta, what is going to happen due to that reason? If the internal laryngeal nerve is injured, obviously the sensory nerve to the supraglottis will be lost, and as the sensory nerve supply to the supraglottis is lost beta, now if anything is trying to enter inside the patient's larynx or inside the patient's airway, will it be stopped by the cuff reflex? Obviously not, because you are not even able to sense that something foreign particle is entering inside the airway beta. So anything which is foreign, which is trying to enter the airway or the larynx beta, will be allowed, because sensory supply nahi hai supraglottis mein. That's the reason patient will not have any kind of cuff reflex, and due to that beta, all the foreign substances will keep on entering inside the patient's larynx or the airway. And if foreign substances enter the patient's airway beta, that is called as recurrent aspiration. So patient is going to develop beta recurrent aspirations due to the internal laryngeal nerve injury which the patient is going to develop recurrent aspirations. Clear? So that has to be remembered. Next, if they say beta, if the external laryngeal nerve of the patient has been injured, if they say external laryngeal nerve of the patient has been injured, now what is going to happen? See, as the external laryngeal nerve is injured, the cricothyroid muscle is going to lose the function. As the cricothyroid muscle loses the function beta, obviously, okay, there will be palsy or paralysis of the cricothyroid muscle. So that's the reason beta, the quality of voice of the patient will get affected. And which kind of voice will be there? The patient is going to have poor quality of voice beta. The patient is going to have a poor quality of voice. Clear? That is important. So if they say beta, the thing that you are answering me, if they say that superior laryngeal nerve is injured, now मुझे ये बताओ, if they say superior laryngeal nerve is injured beta, that means both the branches have been injured, internal laryngeal nerve as well as the external laryngeal nerve. As internal laryngeal nerve is injured, patient should have recurrent aspirations, and as external laryngeal nerve is injured, patient should have poor quality of voice. दोनों दिया हुआ है क्या क्वेश्चन में बच्चे? दोनों दिया हुआ है क्या क्वेश्चन में? नहीं दिया ना? What they are saying, the patient is having recurrent aspirations beta, but without any change in voice. Voice is normal. So now answer the question. Recurrent aspirations are there, but without any change in voice. What is the answer now? This is a recent question of your examination. And they rather complicated the question. The nerve which is supplying the area above the vocal cords has been damaged. So we know the nerve. Yes, it has to be option B, ILN only. Only ILN, only internal laryngeal nerve. Because if the SLN would have been injured, patient would have had aspirations along with poor quality of voice. But here there is only aspiration beta without any poor quality of voice. So it is only the damage to the internal laryngeal nerve beta. If both the symptoms would have been seen, then definitely it was a case of option A beta superior laryngeal nerve. RLN कहाँ से आ गई? RLN का संबंध ही नहीं है यहाँ पे. Clear? So hopefully that's clear to all of you now. ठीक है? ये गलती मत करना एग्जाम में. Do not make this mistake ever in exam. एस्पिरेशन मतलब SLN ये रट के नहीं बैठना है. ठीक है? दिस इज द फंडा. कोई बड़ा कौन सा लॉजिक है इसमें? नॉर्मल है. ठीक है? नाउ डू नॉट मेक दिस मिस्टेक. SLN मतलब बोथ द सिम्टम्स. ILN मीन्स ओनली रिकरेंट एस्पिरेशन. ELN मीन्स ओनली पुअर क्वालिटी ऑफ वॉइस. चलो चला. Unilateral RLN injury may definitely cause beta hoarseness of voice, and bilateral RLN injury, if they ask you beta, so it usually causes bilateral RLN injury, if they ask you beta, so it commonly causes bilateral abductor palsy when both the vocal cords go in a closed position beta. Patient has respiratory distress and stridor. So that is the bilateral abductor palsy, that is due to bilateral RLN injury beta. Okay, so that has to be remembered. So if you want, you can write also over here so that you do not get confused. Unilateral RLN injury may only cause hoarseness of voice, but bilateral RLN injury beta leads to a bilateral abductor palsy. Now clear? ठीक है, चलो. Now answer this next question out here. What is that? Here we have a 58-year-old male beta presents to us with persistent fullness. Who presents to us with persistent fullness beta? Yes. So 58-year-old male beta presents with persistent fullness of left ear for almost 3 months now, along with hearing loss. Okay? Along with hearing loss. On examination, there is fluid behind the tympanic membrane, बच्चे, and impedance audiometry, also called as tympanometry बोल सकते हो उसको. So impedance audiometry or tympanometry shows a type B curve, and we know type B curve is nothing else but a flat curve beta. So type B or a flat curve is seen definitely. ठीक है? The next step for the management of this patient will be. The next step for management of the patient will be. So here beta, there is fluid behind the tympanic membrane, and as there is fluid behind the tympanic membrane बच्चे, so here we know fluid collection behind the tympanic membrane, that means inside the middle ear cavity, is a classical case of glue ear beta. ठीक है? It is a classical case of glue ear, and that glue ear is also called as serous otitis media. I can even call it as secretory otitis media, or we can even call it as otitis media with effusion. The new name which is there beta, do not get confused if this you find in the option, that is one and the same thing. So glue ear, serous otitis media, secretory otitis media, or otitis media with effusion. Now in this condition, do remember one thing beta, that in glue ear or otitis media with effusion, there is a thick sterile glue like fluid which collects in the middle ear. Why? Because the eustachian tube which is there beta, which is responsible for drainage of the middle ear, okay, that eustachian tube has been blocked. And as the eustachian tube is blocked beta due to any reason, definitely please remember beta, here what is going to happen, the middle ear will not be able to drain its secretion, and as the middle ear is not able to drain the secretion beta, a lot of secretions will keep on collecting inside the middle ear cavity, and this condition leads to a glue ear. Now in patients of glue ear beta, obviously the patient is going to suffer from a conductive hearing loss, right? The patient is going to suffer from a conductive hearing loss beta. Okay? And the patient may have heaviness in the ear. Pain is not a feature, reason is it is not an infection, so pain is not seen. So heaviness in ear beta along with some conductive hearing loss is the main complaint of the patient of glue ear beta. When I do a otoscopy, you are able to see beta fluid collected inside the middle ear cavity bache, like this. Can you see? This is the intact tympanic membrane, and behind the intact tympanic membrane beta, there is fluid. You will be like, so what are those bubbles? Those are the bubbles beta inside the fluid. Yes. In the fluid, definitely, as there is some air which is mixed beta, due to that there is those air bubbles which are seen. Okay? So this is a classical picture of glue ear beta. Okay? That is seen. Now important is, then you can go for impedance audiometry or a type on which you will be able to see a type B or a flat curve, because the ear ossicles are not able to move properly due to that fluid which is collected. Okay? And the treatment, if they ask you beta, it can be myringotomy with grommet insertion. Okay? Myringotomy is what? Making an incision over the tympanic membrane, draining all the fluid, and then insertion of a grommet. Can you see the grommet has been inserted in the antero-inferior quadrant? The grommet has been inserted in the antero-inferior quadrant. This is the grommet which is inserted. But we know beta, what is the most common cause of a, so what is the most common cause of a glue ear? Bolo. What is the most common cause of glue ear? The most common cause of glue ear beta is nothing else but adenoid hypertrophy. What happens due to this? When there is a adenoid hypertrophy bache, when there is a adenoid hypertrophy, what happens is usually, this is the nasopharynx, okay, and this is definitely the eustachian tube on both the sides. So when there is adenoid, we know it is exactly present in the posterior part of the nasopharynx beta. This adenoids may grow and it may block both the eustachian tubes beta, and that can cause a bilateral gruyere. Yes, so adenoid hypertrophy which is there beta, it is the most common cause of gruyere and it usually causes a bilateral gruyere in the patient as well beta. Okay, and we know adenoid hypertrophy develops due to recurrent upper respiratory tract infections, and adenoids are only present in children beta. So adenoid hypertrophy is usually more common in school age children. That's the reason these patients may develop a gruyere beta, but in a school age child. Adenoid hypertrophy may cause a gruyere, but usually in a school age child beta, not in an adult definitely. Okay, if an adult there is a gruyere beta, and that to a unilateral gruyere, they are saying unilateral gruyere, okay, and that to an adult patient, and adult be kitna, more than 50 years of age beta. Now please tell me, if an adult patient more than 50 years of age, okay, if an adult patient more than 50 years of age beta, he is having a unilateral gruyere, I hope all of you are going to suspect something, right? I hope all of you are going to suspect something, not directly jump to a conclusion of the answer. Okay, और क्या suspect करोगे? That this patient who is more than 50 years of age may have a hidden cancer which arises from the area behind the eustachian tube opening, and that area is called as fossa of Rosenmuller. And as there is a tumor arising from that fossa of Rosenmuller beta, that tumor or that cancer may block the eustachian tube, and that is the reason for the unilateral gruyere of the patient. Right? And this condition which is there is known as a NPC, nasopharyngeal carcinoma. Right? And we already know beta that nasopharyngeal carcinoma is a hidden cancer. We already know that nasopharyngeal carcinoma is an occult cancer or hidden cancer. It does not present to us commonly. What is the most common clinical presentation of NPC? The most common clinical presentation of NPC is not some obstruction over here, not gruyere. The most common clinical presentation of NPC beta is a metastatic, painless cervical lymphadenopathy. Yes, it is such a hidden cancer that it presents to us in the very late stages beta, when it has already spread or already metastasized to the cervical lymph nodes beta. So it presents to us with the metastatic, painless cervical lymphadenopathy. PYQ yaad rakhna hai baat. ठीक है? So therefore it is not picked up in the early stages beta. If they ask you what is the triad which is seen, so we know the triad that is seen in patients of nasopharyngeal carcinoma is called as a Trotter's triad bache. So it has to be the Trotter's triad which is seen definitely beta, and Trotter's triad can be remembered with the same mnemonic, that is NPC bache. And what is the triad of NPC? N stands for neuralgia beta. So neuralgia means a severe pain due to nerve involvement or nerve irritation beta, and this neuralgia which is there, it is due to fifth cranial nerve or the trigeminal nerve involvement beta. So due to fifth cranial nerve or trigeminal nerve involvement, the patient has a severe neuralgia in this region. Okay. Second, P stands for palatal palsy beta. We know palate is usually supplied by the 10th cranial nerve. So if the patient is having a palatal palsy, that is due to the 10th cranial nerve, that is your vagus nerve involvement. So due to vagus nerve involvement beta, the patient is going to have palatal palsy. And third, the patient is going to have unilateral conductive hearing loss beta due to the unilateral gruyere which is seen due to a nasopharyngeal carcinoma. I hope all of you are quite aware about this NPC over here. N for neuralgia, P for palatal palsy, and C for unilateral conductive hearing loss. So hopefully that's clear to all of you now. So that is a feature of NPC beta, nasopharyngeal carcinoma. Please tell me what is the most, we know the most common site I have told you for nasopharyngeal carcinoma beta is the fossa of Rosenmuller. The most common site for nasopharyngeal carcinoma is fossa of Rosenmuller. Can anybody tell me which is the infection associated with nasopharyngeal carcinoma? Which is the infection associated with nasopharyngeal carcinoma? The viral infection associated with nasopharyngeal carcinoma. Important question. Very good. So the infection which is associated with nasopharyngeal carcinoma, shabash, it is nothing else but a Epstein-Barr virus infection beta. It is nothing else but the EBV infection it is associated with. Shabash. It is associated with commonly EBV or Epstein-Barr virus. हमें पता है Epstein-Barr virus infection is commonly associated with cancers like first NPC or nasopharyngeal carcinoma. Second, post-transplantation lymphoma. After transplantation, if there is a lymphoma. Third, Hodgkin's lymphoma. Fourth, non-Hodgkin's lymphoma. And fifth, a type of non-Hodgkin's lymphoma, especially in African children, called as Burkitt's lymphoma. So these are the cancers with which Epstein-Barr virus is very commonly associated with. ठीक है? What is the treatment of nasopharyngeal carcinoma? बताइए दो अभी. what is the treatment of a nasopharyngeal carcinoma? For investigation, you can do a nasopharyngeal endoscopy and a biopsy has been taken beta, and that can confirm your diagnosis. Treatment क्या करोगे बताओ? Treatment for a nasopharyngeal carcinoma, not for Gruyere. Gruyere की treatment तुम्हें सबको पता है. Treatment for Gruyere which is there beta. Here I am writing, it is myringotomy with grommet insertion, with or without adenoidectomy. If adenoids are hypertrophied, you also have to remove that. Treatment for NPC, shabash. It is chemoradiation beta. So do remember that. It is usually chemoradiation to be remembered. ठीक है, for a nasopharyngeal carcinoma beta. बेटा लारिंजल कैंसर की नहीं पूछी थी ट्रीटमेंट, मैंने एनपीसी की पूछी है ट्रीटमेंट. T1 T2 T3 T4 कुछ नहीं है. सो इट इज कीमो रेडिएशन. ठीक है. एंड दो सेइंग रेडियोथेरेपी बेटा बहुत पुराना हो चुका है. FMG सोल्यूशन से बाहर आओ. That is important. FMG solution में the question which is mentioned beta, it is a very previous year question 2017-18 when the treatment was radiotherapy, but since 2019 itself beta the update is chemo radiation. तो उसमें वो आंसर अब तक बदला नहीं गया है. They have rather added a new question where they have answered it as chemo. So yeah, chemo radiation. ठीक है. So please remember chemo radiation is always better. अगर option में नहीं है then you can mark radiotherapy. Previous answer was radiotherapy beta. Now the best answer has to be chemo radiation. Do remember that. Do not get confused. Okay, a lot of people ask me this doubt, so do remember chemo radiation is the best answer. Okay, chalo. So here beta, 58-year-old male patient presenting to you with heaviness or fullness in the left ear beta. Okay, for 3 months along with hearing loss, fluid behind tympanic membrane. So the patient is having a unilateral Gruyere, that is even confirmed by further impedance audiometry, which is showing you a flat curve. And unilateral Gruyere in a patient of who is more than 50 years of age beta, more likely cause can be a NPC. So first try to rule out NPC बच्चे, otherwise the cancer may not get treated itself. The patient may die due to that. ठीक है, तुमने Gruyere तो treat कर लिया, but main cause ही treat नहीं किया, वापस से Gruyere हो गया patient को. ठीक है, so that is important beta. So answer has to be option C. Endoscopic examination for a nasopharyngeal pathology has to be checked for. Endoscopic examination for a nasopharyngeal pathology like a nasopharyngeal cancer has to be done. Rule it out first. ठीक है. Valsalva maneuver is not done over here beta. It is done when the eustachian tube gets closed when you are taking off beta, when there is a sudden change in the air pressure. ठीक है. Antihistaminics is not given over here. Hopefully this is clear to all of you. Chalo. Moving further. Question number 15. Important question again. Here they asked beta, a patient has presented to you. Okay, a patient has presented to you beta with a sudden onset right-sided facial weakness, along with tingling sensation and drooping of the mouth on the right side beta with headache. The patient was advised oral steroids bachche and acyclovir, okay, along with acyclovir, but after 3 weeks the patient returns with no improvement beta. What should be the next best step in the management of the patient? We know if the patient is having a sudden onset unilateral facial weakness beta, along with tingling sensation, drooping of mouth on the affected side, it is a classical case of a facial palsy, right? It is a classical case of a facial palsy beta, so that has to be remembered. If I talk about facial palsy bache, that is your 7th cranial nerve palsy, in this definitely remember that there are multiple causes for it beta. Facial palsy ke there are multiple causes, ठीक है? Most of the times it is idiopathic also. This you can see beta, these are the features of facial palsy. What is seen on the affected side which is there beta, there is loss of wrinklings. Reason is beta, facial nerve is going to supply all the facial muscles. So if the facial nerve has been damaged, the facial muscles will also get paralyzed. Okay, so here the occipitofrontalis muscle gets paralyzed beta. That's the reason definitely there is loss of wrinkles. And as there is loss of wrinkles beta on the affected side, so there is loss of wrinkles on the affected side bache, ठीक है. And important is, please remember, loss of wrinkles is usually only seen in a lower motor neuron facial palsy. It is only a feature of lower motor neuron facial palsy beta. Reason, याद रखना है, lower motor neuron damage beta, the tone of the muscle decreases and therefore the muscles are paralyzed, but and therefore there is a flaccid paralysis. But in upper motor neuron damage, beta, we know the upper motor neuron damage mein the tone of the muscle usually gets higher. The tone of the muscle increases, and therefore there is a spasticity which is seen, beta. Spastic paralysis is seen. So upper motor neuron lesions mein or upper motor neuron facial palsy mein wrinkles will be present. Loss of wrinkling is only seen in lower motor neuron facial palsy, and that is a keyword to diagnose LMN palsy of facial nerve, beta. Clear to remember, like clear? Next important, beta, here you can see on the affected side the angle of mouth is going down. So on the right side, beta, the angle of mouth is going down. So drooping of angle of mouth on the affected side, beta. Either I can say drooping of mouth on the affected side. Okay, so drooping of mouth on the affected side is seen, or we can say deviation of angle of mouth on the normal side, beta. Either you can say drooping of mouth on the affected side, I find that easy, ठीक है, वो लॉजिकल लगता है मुझे थोड़ा, और you can definitely say deviation of angle of mouth on the normal side, ठीक है, deviation of angle of mouth on the normal side, because the normal side the muscles will be working, beta, and that's the reason definitely they are going to pull the angle of mouth towards their side. Okay, so deviation of angle of mouth on normal side or drooping of angle of mouth on the affected side is a classical feature. Apart from that, on the affected side, beta, when the patient tries to close the eye, the patient's eye will not get completely closed. Reason is, beta, this orbicularis oculi muscle which helps in closing the eye is also a facial muscle supplied by the facial nerve. So if the facial nerve gets damaged, beta, the patient will not be able to close the eye completely because palsy of this orbicularis oculi muscle, and this condition where the patient is not able to close the eye completely is called as lag of thalamus. Lag of thalamus की अगर मैं बात करूँ बेटा, in lag of thalamus definitely the eye of the patient is constantly open, and therefore a lot of garbage, dust, everything goes into the patient's eye, beta, and that can cause inflammation or damage to the cornea, and that condition is known as exposure keratitis. So the patient is going to develop exposure keratitis, beta, due to this lag of thalamus. Clear? These are the features which are seen in a patient of facial palsy, which okay. So now if a patient is having facial palsy, beta, are all facial palsies Bell's palsy? No. Bell's palsy is a special type of facial palsy, beta. What is a Bell's palsy? Definitely understand. So Bell's palsy बोलने के लिए you have to remember one thing, that Bell's palsy is a sudden onset, idiopathic. Most of the cases में idiopathic only it is. ठीक है. Lower motor neuron facial palsy, and this was the question, beta. Bell's is a lower motor neuron or upper motor neuron. ठीक है. So a sudden onset idiopathic lower motor neuron facial palsy is what is called as a Bell's palsy, बेटा. याद रखना सब कुछ Bell's palsy नहीं होता है, ठीक है. हर facial palsy Bell's palsy नहीं होती है. ट्रॉमा की वजह से जो होती है वो Bell's palsy नहीं होती है बच्चे, ठीक है. So that is important. So sudden onset idiopathic lower motor neuron facial palsy is what is known as a Bell's palsy, beta. That has to be remembered. ठीक है. Some cases of Bell's palsy have been associated with HSV, beta. What is HSV1? That is herpes simplex virus 1 infection, beta. Some association. Some of the cases are associated, beta, with HSV1 infection, that is herpes simplex virus 1 infection, and that's the reason like the acyclovir has been added in the treatment, but that is only effective if you start giving acyclovir within 72 hours of symptom onset, beta. Otherwise there is no use of giving acyclovir. If they ask you what is the drug of choice for facial palsy, beta, anybody? What is the drug of choice for facial palsy? What is the drug of choice for facial palsy? Bolo. So the drug of choice for facial palsy has to be oral steroids, beta. याद रखना, dexamethasone वगैरह, prednisolone वगैरह can be given. So oral steroids, because in most of the cases, beta, the cause has not been found, but rather only it has been seen that there is edema around the facial nerve, and that edema causes compression of the facial nerve. Whether that edema is due to some trauma, it is due to some infection or any other cause, beta, that edema compresses the facial nerve. So therefore the drug of choice is to be steroids because it reduces inflammation and edema, beta, and that shows the improvement. Okay? Even you can give acyclovir, but that's not the drug of choice. Okay? Now oral steroids which are there, beta, they should be given for a span of 3 weeks. Now even after 3 weeks, beta, if the patient shows no improvement, even after 3 weeks, if the patient has no improvement, beta, then what we have to do? Then we have to see the facial nerve fibers, beta, and for that we have to do a electrophysiological nerve testing. For that we have to do a electrophysiological nerve testing. ठीक है. So electrophysiological nerve testing which is there beta, it has to be done. So electrophysiological nerve testing has to be done beta, and after that if you see that the fibers are damaged beta, after that if you see the fibers have been damaged, so if they say the fibers are damaged, in that condition you have to go for a surgical repair beta. In that condition you will go for a surgical repair of the facial nerve or surgical decompression of the facial nerve. So either you can say surgical repair or a surgical decompression of the facial nerve. So here they have said the patient has been given oral steroids for a span of 3 weeks, but after 3 weeks beta, the patient shows no improvement. So what is the next best step? It has been a previous year question. The next best step has to be answer C. So the option has to be answer C beta. Answer has to be option C, that is electrophysiological nerve testing, which will tell you that the fibers of the facial nerve has been damaged. Clear? And then you can go for a surgical decompression of the facial nerve. Okay? So answer for this question has to be option C over here. Hopefully that's clear. Done with this? Okay. Chalo. Next one if I talk about beta is this one, easy one. Here we have a question beta which says a 35-year-old. Here we have a question which says a 35-year-old pregnant female which is there beta, who complains of bilateral gradually progressive. Who complains of bilateral gradually progressive hearing loss bache, which aggravated since the last few weeks beta. The patient was advised tympanometry or impedance audiometry, whatever you call it. Which of the following graph will be seen? We know beta, tympanometry or impedance audiometry checks the freedom of movement of the ear ossicle. How freely the ear ossicle is able to move beta, that freedom of movement is checked by tympanometry or impedance audiometry. So, what is the likely diagnosis of this female over here? What is the provisional diagnosis of this female over here? What is the provisional diagnosis you feel? A young female who is 35-year-old. Okay. So definitely that young female complains of bilateral gradually progressive conductive hearing loss beta. Okay. Bilateral gradually progressive hearing loss they have said. And that hearing loss has aggravated since last few weeks. Why? Because she was pregnant, so therefore it has aggravated since the last few weeks beta. During pregnancy it has aggravated. Very good. This is a very classical diagnosis of otosclerosis beta. This is a very classical diagnosis of otosclerosis in the patient. If I talk about otosclerosis or otospongiosis, we know that what happens in otosclerosis is the foot plate of the stapes which is there beta. The foot plate of the stapes which is there. Around that foot plate of stapes beta, there is a fibrosis which develops. And as there is fibrosis around the foot plate of stapes beta, the stapes is not able to move and therefore the conduction of sound is not able to happen properly. As it is a genetic condition beta, it is usually bilateral. The pattern of inheritance which is followed for otosclerosis is autosomal dominant. Please remember, it is going to more commonly involve younger females beta, and the patients are going to have bilateral gradually progressive conductive hearing loss bache. And we know the aggravation which is there, okay, or worsening which is there, worsening of symptoms, okay. So aggravation or worsening which is there beta, it happens during pregnancy. That is a very classical case of otosclerosis in a patient. Very classical case of otosclerosis. Now in patients of otosclerosis beta, when I do a otoscopic examination, what is the feature seen on tympanic membrane? Anybody? So if the patient comes to us beta in the early stages of otosclerosis, when the patient comes to us in the early stages of otosclerosis bache, in the active stages of otosclerosis, on the tympanic membrane beta, I'll be able to see a very classical appearance. That is called as either the Schwartz sign, that is classically known as the Schwartz sign, or the flamingo pink appearance beta. That is classically called as the Schwartz sign or the flamingo pink appearance. Okay, so do remember that when the patient comes to us in the early stages of otosclerosis, we are able to see the Schwartz sign, also known as the flamingo pink appearance. Shabash. Whereas beta, if I do a PTA, as the patient is having hearing loss, we can go for a PTA or a pure tone audiometry. When we do a PTA or a pure tone audiometry beta, obviously the patient is going to show a conductive hearing loss. And conductive hearing loss ka matlab kya? On PTA what will be seen? The bone conduction of the patient will be normal. The air conduction of the patient will be poor. And there is a significant AB gap beta between the two lines. There is more than 15 decibels of gap between the two lines. Along with that, a very classical feature is seen beta. At 2000 Hertz, there is a dip in the bone conduction. What is that called as? Please let me know in the chat box, jaldi say. At 2000 Hertz beta, there is dip in the bone conduction. So dip in bone conduction at 2000 hertz is classically called as what in cases of otosclerosis? Bolo. Very good. That is classically known as the Carhart's notch, beta. So do remember, beta, that is classically referred to as the Carhart's notch. Okay. So dip in bone conduction at 2000 hertz, which is there, beta. So definitely that is classically referred to as the Carhart's notch. Shabash. Very good. That is important to be remembered. Anybody, can you tell me another one when there is dip at 4000 hertz in air as well as bone conduction? Air conduction or bone conduction, दोनों में if you are able to see a dip, but at 4000 hertz, that is usually known as the acoustic dip. चलो मैं नाम बता देता हूँ. That acoustic dip is a dip in air and bone conduction at 4000 hertz. That is a feature of which conduction? Dip in both the conductions at 4000 hertz. Acoustic dip. It is seen in a case of which conduction? Anybody? Sorry, in which hearing loss? Anybody? Here it is dip in bone conduction, beta. In otosclerosis, there is dip only in bone conduction. In both air and bone conduction, it is usually seen in patients of bolo. Noise-induced hearing loss, beta. Yes, in patients of noise-induced hearing loss, which is there, bache, you are able to see an acoustic dip at 4000 hertz, beta. Very good. Okay, you are able to see that dip in at 4000 hertz in patients suffering from noise-induced hearing loss, beta. That has to be remembered. Now, if they ask you in case of otosclerosis, beta, what has to be the treatment over here? If they ask you what is the treatment, if the patient comes to me in the early stages, beta, I'll come to the tympanometry part. Let's discuss this. If I talk about the treatment, beta, if my patient comes with a positive short sign, beta, then what is the treatment, bolo? As the patient has come to me with a positive short sign, that means patient is in the early or active stages of a disease. We do not need a surgery immediately because we can manage the patient with some medical management. What is that drug which is given, bolo? If the patient short sign is positive, what is the drug that is given? Previous year question of your exam. If short sign is positive in those patients, beta, what is the treatment? Oral. Very good. Shabash. It is the oral sodium fluoride, beta, which is given, which helps in stabilization of the disease, beta. It does not let the condition progress further. So this has been a PYQ. Do remember that oral sodium fluoride is done when definitely short sign is positive. And in the advanced stages of the disease, beta, in the later stages of the disease, then we have to go for surgery. And the surgery which is preferred, beta, is stepedotomy. Yaad rakhna. That is removal of all the fibrotic part, okay, around the stapes, beta. Stepedotomy is usually preferred over stapedectomy. Okay, reason is, if we perform a stapedectomy and you use a piston prosthesis, beta, that is not going to give you the best quality. That's the reason stepedotomy is always preferred. If you can save the stapes, always first try to save the stapes. If saving of stapes is not at all possible at all, then we may go for a stapedectomy. Clear? So that is important about otosclerosis, bache. Now talking about tympanometry. Now in tympanometry, beta, graph which is normally seen, that is called as a type A curve. Okay, a graph or a curve which is normally seen, beta, that is called as a type A curve, where there is neither more movement nor less movement, beta. But in this picture over here, what you are able to see, here there is very less movement of the ear ossicles, beta. Why? Because the ear ossicles or the stapes of this patient have got fixed, and that's the reason it is not able to move. Matlab, this curve which is seen, beta, which is showing you very less movement, is called as a type AS curve, beta, and the S stands for shadi or sclerosis. That means this is a picture of otosclerosis, beta. ठीक है, so definitely शादी के बाद तुम्हारा घूमना फिरना बंद हो जाता है ना बेटा. The same way definitely here also the ear ossicles are not free and they cannot move a lot. Okay, so please remember, in patients of otosclerosis there is a type AS curve which is seen. Next condition which is there, beta, here you are able to see a curve where definitely there is a lot of movement of the ear ossicle. Why? Because now the ear ossicles are free, they are not even attached to each other, they are dislocated, and therefore they can freely move, beta. Larger curve is produced. This is what is called as a type AD curve, beta. So a type AD curve which is there, which it is usually D stands for divorce over here या dislocation, जो भी बोलो, ठीक है. Divorce के बाद freely घूम सकते हो. So type AD curve which is there, beta, it is usually seen in patients of ossicular dislocation. It is usually seen in patients of ossicular dislocation. And next one, this is the type B curve, beta. So this type B curve, you can see it is a flat curve, bache, which is seen. And this flat curve, I have already told you, beta, it is usually seen in patients of glue ear. It is usually seen in patients of glue ear, beta. Clear? So that has to be remembered. It is usually seen in patients of Gruyere over here. Okay. Next important which is there, here you are able to see beta a negative curve, and this curve which is there, it is slightly towards the negative side. Why? Because the tympanic membrane is not moving outside, it is rather pulled inside. What is that condition where the tympanic membrane will be pulled inside? We know when there is negative pressure inside the middle ear beta, the tympanic membrane gets pulled inside, causing retraction beta. And why there will be negative pressure inside the middle ear? Because the eustachian tube of the patient is blocked. So this negative curve which is there beta, it is called as a type C curve, and negative curve or type C curve which is there beta, it is due to eustachian tube blockage. It is due to eustachian tube blockage. So here definitely it is a patient of otosclerosis, so answer has to be option A beta. That is a type AS curve is usually seen in patients suffering from otosclerosis. Okay, so type AS curve is usually seen in patients suffering from otosclerosis. Okay, so there is, chalo, let's do one more question. It's easy, therefore let's do this question itself beta. Okay, okay, so let's do this question once and then we'll call off the session, because I have another session at 10 beta starting, that one liner session. So here you have a 2-year-old child bache. Here you have a 2-year-old child who was brought to in the emergency with respiratory distress and cough. Mother also gives history beta. Mother also gives history of mild fever and noisy breathing. Noisy breathing is stridor. X-ray reveals narrowing in the subglottic region beta. X-ray reveals there is narrowing in the subglottic region. Which among the following will not be considered as primary management? They are saying primary management in this condition beta. What is your provisional diagnosis? First of all, let me know in the chat box. Jaldi se. What is your provisional diagnosis in this condition? The provisional diagnosis of this condition would be what is the provisional diagnosis beta? Ye to bata do. Very good, shabash. The provisional diagnosis of this condition is nothing else but a infection beta of the larynx, and that acute laryngeal infection is what is called as a Krupp beta. Okay, Krupp bolo, jo bhi bolo, also known as acute LTB bache. What is acute LTB? Acute laryngotracheobronchitis. So now here you can see beta there is infection or inflammation of the whole airway, larynx also, trachea also, bronchi also, but okay, that is known as Krupp. But the most common site affected is the supraglottis beta. Do remember that most common site affected which is there beta, it is the subglottis. Most common site affected which is there beta, it is the subglottis, and therefore there is a lot of edema and lot of narrowing in the subglottis region beta of the patient. Okay, now in this condition beta, the cause of Krupp or the cause of acute LTB which is there beta, the most common cause is a not of bacterial but rather a viral infection, and that viral infection which is there beta, it is called as parainfluenza. So parainfluenza virus type 1 and virus parainfluenza type 2. So parainfluenza virus type 1 and 2 beta are the reason for causing Krupp or acute laryngotracheobronchitis in the patient beta. That has to be remembered. Now in this condition, if they ask you beta, what is the complaint of the patient? So the complaint of the patient beta, as there is edema of the airway, the patient is going to have stridor, and we know whenever there will be obstruction at the subglottis beta, the child or the patient is going to have a biphasic stridor. So here the child has a biphasic stridor beta. Second, the child has a very classical cough beta. It seems as if a dog is barking. So this is called as a barking cough beta. Even this cough can be described as brassy cough. So do not get confused if they use the term brassy. Okay, so barking cough bolo or brassy cough bolo, that will be a feature beta. And obviously as there is edema of the airway, the patient may have some respiratory difficulty or respiratory distress. These are the common features with which the patient will come to you, and low grade fever as well. Because it is a viral infection, so there is a low grade fever. When we do definitely a X-ray neck beta, on that X-ray soft tissue neck we will be able to see a very classical feature. On the X-ray soft tissue neck beta, on the AP view or on the anteroposterior view beta, you are able to see there is narrowing of subglottis, and this narrow subglottis which is there beta, this narrow subglottis which is there, it gives you a very classical sign called as the steeple sign. Shabash all of you. So it gives you a very classical sign on the X-ray soft tissue neck known as the steeple sign beta. So this is a classical feature in acute laryngotracheobronchitis or LTB beta. Now what is the treatment? See, please remember the drug of choice or the mainstay of management which is there beta, the definitive management is definitely steroids to be given. The definitive management is steroid. Reason is antivirals have not shown any improvement beta in patients of acute LTB or CROUP. That is the reason antivirals are not used in the management of CROUP beta. They do not have any feature as such, any improvement as such. Therefore, injectable steroids are considered as the important management. Reason, steroids will reduce the inflammation beta, it will reduce the edema, and definitely the patient will feel better beta. That is the reason injectable steroids are the mainstay of management. After this, will we give humidified heliox administration? Yes, humidified heliox. Either only oxygen you can give, or if you have availability, then you can give helium plus oxygen also to the child beta. So humidified heliox administration is also given to the patient beta. ठीक है. Nebulized racemic epinephrine, yes beta, nebulization of racemic epinephrine is given. Reason, epinephrine or adrenaline which is there beta, it acts as a bronchodilator, and as it acts as a bronchodilator beta, it helps in the respiratory distress of the patient. Now important is, will we give antibiotics beta? Yes, antibiotics are given. ठीक है, antibiotics are given, but are they given for the treatment of CROUP? ये बताओ मुझे. Are they given for the treatment of CROUP beta? No. Very good, shabash. So please remember beta, antibiotics which are there given, definitely they are given to prevent, okay, they are given to prevent secondary bacterial infections beta. They are given to prevent the secondary bacterial infection. Now here they have not asked you about the overall management, they have just asked you about the primary management beta. तो अगर primary management पूछ रहे हैं, that means you have to only answer about the management of CROUP. Now here definitely antibiotics, I know we give antibiotics to prevent secondary bacterial infection, but यहाँ पे अगर exception पूछा है बेटा, so definitely antibiotics are not given, ऐसा नहीं है. Antibiotics are given, but they are given for the purpose of preventing secondary bacterial infections, not for the purpose of treating CROUP. ठीक है, तो इसीलिए अगर वो पूछते हैं बेटा that what is not included in the primary management beta, so do remember not be considered as a primary management should be option C. ठीक है, यहाँ इसके अलावा अगर कोई और ऑप्शन होता, then I would have considered कि antibiotics is also a part. But यहाँ पे definitely all other options which are there beta, they are for the primary management of CROUP. Antibiotics are not for the primary management, they are for the prevention of secondary bacterial infection. ठीक है, so that has to be remembered beta. So that has to be remembered. Second is a child who comes to you beta in the emergency with a severe respiratory distress. The child has a severe respiratory distress beta. We know that CROUP which is there, it is more common in children who are between 6 months to 3 years of age. CROUP is more common in children between 6 months to 3 years of age. But now we have a child who is either 2 to 8 years of age beta, and 2 to 8 years of child coming to you with severe respiratory distress बच्चे. The child feels better in sitting position, bending forwards. That is called as a tripod position. The child feels better in sitting position, bending forwards, called as a tripod position. The child is going to have, it will be painful for the child beta even to swallow the saliva. Therefore, there is continuous drooling of saliva from the baby's mouth beta. The child does not even swallow the saliva because that causes a lot of pain. There is a continuous drooling of saliva from the baby's mouth बच्चे. That has to be remembered. ठीक है? So do remember that. Apart from that, definitely the baby which is there beta, the baby will have a high grade fever because this is a bacterial infection which will be seen, and the baby is going to have a hot potato like voice beta. This kind of a voice will be seen in the baby. This is what is called as a hot potato or a muffling voice. ठीक है, this is what is a hot potato or a muffling voice बच्चे, which is usually seen in the patient. ठीक है, that is usually due to inflammation or edema in the airway of the child. ठीक है, all these features have to be a very good, a classical case of acute epiglottitis beta. And if I talk about acute epiglottitis, we know it is infection of the supraglottis beta, but the most common site affected is the epiglottis. What is the most common cause of acute epiglottitis? Bolo. Most common cause of acute epiglottitis beta. Most common cause of acute epiglottitis. So the most common cause of acute epiglottitis is nothing else but Streptococcus pneumoniae बच्चे. Yes, most common cause, rather leading cause of hauteprothovitis is quinsy beta. Other causes can be supraglottic cancer, base of tongue cancer, or or it can be definitely a acute epiglottitis or acute retropharyngeal abscess. Okay, these are the other causes. Very good. So Streptococcus pneumoniae beta, also called as pneumococcus, is the leading cause of acute epiglottitis. Do remember that. Most common cause is Streptococcus pneumoniae or pneumococcus beta. But if they say unimmunized child, beta, ठीक है, if they say unimmunized child, ठीक है. Then definitely your answer has to be beta. If they say unimmunized child beta, then your answer has to be HIB. What is HIB? Haemophilus influenza type B beta. Then your answer has to be HIB, that is Haemophilus influenza type B. तो अगर unimmunized है बच्चा then HIB, but immunized child है तो he would have got HIB vaccines beta, and therefore the incidence of HIB infections is decreasing. Clear? So that has to be remembered. No issues with this, as it is a bacterial infection. All these symptoms will be there in the patient beta, and definitely there will be a red and a swollen epiglottis, and that red and swollen epiglottis which is there beta on the X-ray soft tissue neck. Okay, on the X-ray soft tissue neck lateral view, on the X-ray soft tissue neck lateral view beta, you will be able to get a very classical sign. And what is the sign that you will get on the X-ray soft tissue neck lateral view? This inflamed epiglottis which is there beta, it will give you a classical thumb sign bachche. It will give you a classical thumb sign. So an inflamed epiglottis will give you a classical thumb sign beta. Okay, on X-ray soft tissue neck lateral view. Sarkari question. Now we know beta treatment. If they ask you what has to be done for the purpose of treatment, so you have to remember only one thing. You have to give IV antibiotics to the patient because it is a bacterial infection. You have to give injectable steroids to the patient because we have to reduce edema and reduce the inflammation. We have to give bronchodilators. For that definitely you can give nebulization of epinephrine or adrenaline beta. And we also have to give beta oxygen administration to the child. Okay, so all these 4 things are also done over here, but here antibiotics which is there beta, it will be the mainstay of management, or it will be the primary management in acute epiglottitis. Clear? Thumbprint nahi beta. Thumbprint sign is usually seen in ischemic colitis on barium enema. Ischemic colitis on barium enema shows the thumbprint sign. Clear? Yes. So first, अगर हाँ definitive management है, अगर वो first step management पूछते हैं बेटा और emergency management पूछते हैं, तो first management, emergency management, always take care of the patient's airway, whether it is a case of Croup or it is a case of acute epiglottitis. Whether it is a case of Croup or it is a case of acute epiglottitis, the first step has to be airway management. And in airway management also beta, we have to do a early elective intubation. Why early elective beta? Because if you delay the intubation, the edema of the child will keep on increasing, and then even the vocal cords of the child will not be visible beta, and then intubation will become very difficult. That's the reason airway management, early elective intubation should be your first priority or emergency management, both in cases of acute epiglottitis and even in cases of Croup beta if the child is having respiratory distress. Clear? Chalo. So that is important. So chalo, let's call off the session. I've tried to cover a lot of important things. There are still some questions. I'll post the PDF in the group beta. Do not worry about that. Okay? So from 10 onwards, I'll be starting a session. So you can take a break, and from 10 onwards, I'll be starting a session in Phoenix. Prep for next. This is the Telegram group. If you want revision of one-liners, bache, okay, we will try to cover definitely a lot of one-liners in the same Telegram group itself. Okay? So yeah, I'll cover a lot of one-liners. Yesterday also there was a session for 1 hour. It was conducted. So I'll be asking random questions. You will be asking. You will be giving random answers. But a lot of things would be covered in that. So it will help you better. It will definitely help you in the active recall of the questions. Chalega? Chalo. My pleasure, bacho. Take care. All the best. And see you after some time. Okay?